First of all, I would like to thank all the MRCOG team, by the way, for the wonderful job collecting these questions. Okay, so Dr. MB and Dr. Nada, everyone, thank you very much, guys, for the great job that you have done. Make it easy for our friends to review the important questions from the January 2025 and learn their lessons. So here is a single best answer question. Expanded carrier screening, or ECS, is a blanket blood test for many genetically associated disease. Expanded carrier screening is available to partners of carriers of genetically associated disease, as recommended by the NHS of England, okay, the National Genomic Directory. The NHS England genomic test directly stated a cut-off carrier frequency above which the test could be offered. What is the minimum carrier frequency of a genetically associated disease for this screening test to be offered? How many of you know what we are talking about? No problem. No problem. Okay, so we are not going to start with crying. We will just, okay, learn the lesson, okay? It's actually, they give you the intro, right? They said that it's just a type of genetic test that identify individuals who carry one or more gene mutation, right? And this is because of the inherited genetic condition, right? Okay, so by the way, this test, they are very proud of it, okay? It's been nowadays offered to people who have children with possible inherited problems, okay? So now, my friend, there is a cutoff, okay? Yes, no problem. You can put any answer in the exam and go. What is the, I'll tell you, Dr. Amra, okay? You don't know anything about this topic and you don't know anything about the cutoff, right? And you have decided to leave it quickly. You should put an answer, right? What is the chances that you get the correct answer? 20%, right? The single best answer question, right? So what is the chances that any answer you will put will be correct? Right? Okay, so you have 20% chances. Even the question that you never heard of, right? See, this is easy. Okay, so it's the cutoff is 1 in 70. Okay, 1 in 70. So please, no problem, leave your luck, no problem, Dr. Sarah. We don't need your luck today, okay? Best of luck, inshallah, but just be confident, okay? And don't let a question like this break your confidence before starting the exam. They used to do so, by the way. And the most difficult questions or the most strange questions will come at first. Maybe first or second question will be the same in the exam. Don't be stressed out. I'm just warning you, okay? Okay, good. So it's 1 in 70, right? Who deals with the national alert from Department of Health in the local unit? There is what is called the National Patient Safety Alerting Committee. Has been established to improve the effectiveness of these safety critical communication and to support the provider to better implement the required action. The key way, okay, of this National Patient Safety Alerting Committee is doing this through the introduction of the National Patient Safety Alert. Okay, so if there is an alert, okay, who will be responsible, okay, in the local unit to receive this? The medical director, yes. Well done, Dr. Fatima. Okay. So this is the medical director. Easy, right? Okay. Okay, so this was an expected question. Okay, the medical director is job, okay, is like a lead of the organization, right? Okay, so engaged with GPs, local authorities, place representatives, do the paperwork, and it represent, right, the hospital or the trust in front of the other governmental organization, right? The clinical director will be responsibility to ensure that the service is adequately resourced and organized to fit the purpose, okay? So responsible for the work in the hospital, the clinical job of the hospital. The director, okay, will be responsible for other things, not only it's not about the surface or about the clinical practice or ensuring the the clinical things or organizing the inside of the management, but how is dealing with the other organizations, because the hospital work not alone, right? Work in a government, right? So okay, so the answer is highlighted already, my dear. So you're saying that answer should be highlighted. It is highlighted. Okay. Should not be highlighted? No, no, it's not a test today. Believe me. It's not a test today. I don't want to put you under the test. We're just learning from the questions, okay? So what is acceptable maximum operating pressure for a woman undergoing elective laparoscopic appendectomy at 25 weeks of gestation? This is a repeated question, right? So, okay. So the lowest or the minimum, yes, the minimum or the lowest, my dear, operating pressure is less than 12, okay? This is if they tell you that I'm answering one of my friends in the chat box, okay, asking about what is if minimum, right? So the answer will be below 12, right? But so the question would be very clear, right? Okay. When asked about the maximum, right? This is up to 15, right? The lowest operating pressure less than 12. Okay, Git? Okay, dear? So this is different between maximum and minimum, right? So before inserting the primary trocar, okay, it's like 20 to 25, right? But the operating pressure around 12 to maximum 15. Are we happy so far? So a 21-year-old Asian woman working as waitress in her second pregnancy. She is in her second year of medical school. She is living with her husband and her parent. She had uneventful first pregnancy and delivery. What is her highest risk for mortality in this pregnancy? Yes, it's the ethnicity, right? And from the embrace, okay, the maternal morbidity and mortality report, okay, there was unfortunately, okay, in the report, prove that there is inequality in the maternal mortality and the ethnicity actually is making a difference. So they found that 3 times higher risk in Black African women, and this came before in the exam, asked it before in the exam, and 2 times for Asian women, right? And 2 times higher in the most deprived area. 3 times higher for older patient age 35 or older. Obesity also or overweight have an effect, but this is by 64%. Okay, so the ethnicity is around, okay, 3 times higher in Black, 2 times higher in Asian. My friends, believe me, I want to do everything with you, okay? But we have really very limited time and so many questions to cover, okay? So we can discuss other things, but we will not be able to finish a good bulk of the question, okay? So please, we let the priority now for reviewing the questions, okay? Any other things or any other request or material, you can just send it to the group and we can answer it. So for the first time since the Embrace UK reporting began, thrombosis and VTE was the leading cause of maternal death in the UK. So you have heard this information before, correct? So now, my friend, the very common question in the recall used to be answer is cardiac disease, right? Now it's not cardiac disease. In the latest report, it's a thrombosis and VTE, okay? So the question here, asking for the COVID, thrombosis and VTE, right? And cardiac disease. Together, these 3 accounted for what percentage of maternal death? Here, my friend, Embrace report, blood clots, what is the percentage? 16. COVID, 14. Cardiac disease, 13. Mental health condition, 11. Sepsis, 9. Epilepsy, 9. Then other physical conditions, 7. Obstetric bleeding, 7. Early pregnancy, 5. And other direct causes, 4. So, my friends, now if I ask you about the percentage of the top 3 diseases, it's the 43. Okay, friends? Be careful of this question because you either know it or you don't know it in the exam. What is the period associated with highest risk of VTE in pregnancy by IVF? First, second, third, or postpartum? For IVF, it's the first trimester. That's why many centers, many IVF centers will actually give the patient low molecular weight heparin, right? For the first trimester. So remember, it's the first. Patient underwent ovum retrieval in a European country. She presented with mild pain, nausea, 2 days following the retrieval. Her examination showed a normal temperature. Ultrasound show ovarian size of 12 with free fluid in the pelvis. Her labs show mild elevation of the total leukocytic count. What is the possible diagnosis? So you do have OHSS, but which category of the OHS? Okay, so in the OHSS, right, we do like this. If mild pain means it's a mild OHSS, but since he give you that the ovarian size 12 means that we are in the moderate, okay? So you will take the upper one. Upper class, okay? So well done, it's moderate. Patient was started on Relugolix, estradiol, noritestosterone regime for treatment of fibroid. What is the mechanism of action of the religolix? Yes, excellent. This is GnRH antagonist. Okay, a non-peptide GnRH receptor antagonist. Yes, okay. Which of the following is a component of the puke scoring system in the nausea and vomiting? So this is the puke, right? Oh, sorry. In the last 24 hours, how many times have you had retching or dry heaves without bringing anything up? In the last 24 hours, for how long you felt nauseated or sick to the stomach? In the last 24 hours, have you vomited or thrown up? Right? So here, it's in the last 24 hours, right? They are asking about the last 24 hours, not 48, not 72, not 96. An epileptic patient came with a history of unprotected sexual intercourse 36 hours ago. Her epilepsy well controlled with carbamazepine. She's in her mid-cycle, her cycle regular. And what is the emergency contraception of choice? So, my friends, even if he tell you double dose of the levonorgestrel, what is the best still? The best still will be the copper IUD. Yes. Okay, so once the copper IUD is there and no contraindication, it's your choice. It doesn't matter, Dr. Fatma, it's a mid-cycle or not mid-cycle, you can still give everything, but still copper IUD is a bit. Okay, even if he told you that this is the first week of the cycle, it's still copper IUD is the best. Okay, 100% it's your first choice unless contraindicated. Patient presented with vulval lesion, okay, as shown in the picture, showing symmetrical erythematous plaques with no scaling. What is the possible diagnosis? In the vulva, no scaling. But it could be scaly lesion elsewhere, right? So well-demarcated, brightly erythematous plaques, usually symmetrical on outer labia majora and mons pubis, right? May also extend into the inguinal folds, perianal skin, or the natal cleft. Okay? Patient on treatment for IVF for endometriosis presented with severe pain after ovum retrieval. On examination, she had severe right pelvic tenderness and palpable mass. So there was a mass. Temperature was 39 degrees, okay? And the total leukocytic count is 13,000. So, what do you think? Yes, so yes, so you do have a mass and you do have a high temperature, right? With severe right pelvic tenderness and a palpable mass, right? So in this case, you would think of With the high temperature, you will think of something that infection. What type of infection that can occur and at the same time can give you a mass? It's the pelvic abscess or the tube ovarian abscess. Mesh complications should be reported to which organization? That's easy, MEHRA. So this is what you need to remember about the mesh complication. What is the risk of affected offspring when both parents affected with the Huntington disease? The Huntington disease or the chorea, okay, is what? Dominant. Okay, good. So if it is dominant, so what is the chances? So 3 to 4 will be affected and only 1 in 4 will be unaffected. Yes, no carrier, Dr. Lena, of course. Postmenopausal woman was evaluated for microscopic hematuria. Her cystoscopy normal. What is the next investigation recommended for her? So we know that if I have a patient with microscopic hematuria, 3 tests can come in my mind, right? The urine cytology as initial, right? Cystoscopy is a must to rule out cancers or masses, okay? And you need a QB, right? Okay, so if the cystoscopy normal, so what you will do next? In the presence of persistent microscopic hematuria, urine cytology is usually indicated and cystoscopy considered. Persistent microscopic hematuria should be managed in accordance with the local protocol for investigation of hematuria, right? Okay. The most common ECG finding associated with pulmonary embolism. That's all the question, right? Yes, so the one, okay, which contain the S1Q3T3 also with T-wave inversion. So the ECG abnormal in 41% if the patient comes with acute PE, the most common abnormality, T-wave inversion, okay, at 21%, okay? So this is the most common one. No, it's not incorrect. It's which one is the most common. So one says 21% and the right bundle block is 18% during the pregnancy. So which one you will go for it? You will go for the 21, of course. 15-year-old hockey player present with heavy menstrual bleeding. Period was regular. Mother mentioned that she gets easily bruised whenever she plays her sport. So how do you evaluate her? Whenever you have heavy menstrual bleeding since menarche or in that age, what you will do? Vulval disease, right? Yes. Excellent. Okay. Yes. Yes, we do the coagulation profile, okay? But patient as well, she is easily bruised, okay? So what is the most common disease that can cause this presentation? It's the von Willebrand. This is a 16 question, my dear. Okay, most common ECG associated. I want the one with the T-wave inversion. I need the one with the T-wave inversion because it is the most common abnormality. Okay? Right? Young girl was examined and found to have recently underwent FGM. Anybody below 18 years and have FGM, which is I'm here, my friends. Okay, so what you will do for less than 18? I'm here, my dear. I just have like lots of connection for a few seconds. How many days? 1 month, right? Is it when within 1 month? Reporting to the police is mandatory, right? This is part of from the FGA law. If the FGM is confirmed in a girl under 18, either on examination or because the patient or parent says it has been done, reporting to the police is mandatory, and this is must be within 1 month of confirmation. It's a previous exam question, right? Okay. Okay. So, my friends, if somebody above 18 or 18 and above, okay, can I inform the police without their consent? No, we can't, right? So have to respect, right? Sexual assault and she doesn't want to report to the police and she's 18 or above. What you will do? So we can offer her all types of support, but we are not going to inform police without her. Without her consent, okay? That's very important. We don't do any referrals without patient consent while she is 18 or above. Yes, even if fresh, okay? So we can read the guideline and we can read the sexual assault article. And by the way, this is a famous case in the part 3. Very famous question, a whole station about it. Patient doesn't want to report that she is adult, respect her wishes. Okay? FGM, same. Okay? We can't report or refer any adult to anywhere without their consent. Okay? Even domestic violence, Dr. Muhammad, the only reason that will make you report a domestic violence while the patient is not giving you a consent that there are children at home at risk. Okay? So the most important thing that you are responsible for the patient, okay? That below 18, this is when you do your job for the safeguarding. Okay? You do de-infabulation after cesarean. Okay? You can do it in the postnatal follow-up. What's the problem? Okay? Not before discharge. Why before discharge? In the no, in the postnatal follow-up after this in the clinic. Postnatal clinic. And you can discuss it. Yes, if the patient is below 18 and she is under any type of assault or violence, you have to inform the police and the safeguarding, of course. What is the time of reporting to the police when you confirm FGM? Yes, I will go with the guideline, right? Within 1 month in the guideline. Okay? And guys, I'll tell you something very important, okay? If you still have a doubt about a topic and someone is asking about a priority, right, in a study. So what I can see here from your answer in the chat box, because you are writing so many comments, okay? You haven't revised the FGM recently, okay? So go and revise the FGM. If you do have a problem with a guideline, revise it. This is the time when you revise, okay? This is not the time when you take information just from a meeting or a social, group. No, revise the guideline, clear your concept, okay? This is one of the guidelines that is a must to do, okay? You will have this guideline under the antenatal or under the legal problem, okay? What is the most common site of perforation of the uterus during the surgical termination? Yeah, anterior. Okay. A young patient presented with heavy menstrual bleeding associated with pain, cycles were regular, full blood count show reduced hemoglobin. How to manage her? Since he said associated with pain means what I need to give? I will give non-steroidal, right? And what is the best that it can help me? Mefenamic acid, right? Okay. Yes, good. Young patient presented with heavy menstrual bleeding, cycles regular. She doesn't want hormonal contraception. How to manage? Now he didn't tell you pain. What he said is only that non-hormonal. Yes, tranexamic acid in this case. No pain, then tranexamic acid. A previous one was mefenamic acid because she had pain. Patient at 41 weeks of gestation refused induction of labor. How to proceed? Yes, I would respect her choice. What I will arrange also, because I am not sure of the options. Yes, I would arrange a twice weekly CTG and ultrasound weekly for the amniotic fluid, assessment of the amniotic fluid, right? Yes. Okay. So I will, yes, I will respect her wishes. In the same time, I will arrange for the follow-up. Yes, for fetal surveillance. Well done. Shoulder dystocia training should be offered by what? Amniotic fluid assessment. Okay, the most important thing in it, the vertical pole. Yes. Yeah, so shoulder dystocia will need a simulation, right? Right? Yes, of course, you need a mannequin, right? Okay. So in the option, in-house training, outside training, multi-professional in-house training, group training, one-to-one training. Yes, you wanted in-house training. In-house training alone or multi-professional in-house training? The multi-professional, yes. Okay, so I'll tell you something, my friends. Who receive shoulder dystocia training? Everyone who's working in the field of the obstetric, right? Correct? So this is who receive, right? Okay. Means that midwives will receive? Yes, sure, they must receive, right? Do you think that neonatologists can also receive a training? They would receive, yes, some training about that. At least they must know it, okay? Okay, because they also have their own training for the, how to examine the baby afterwards. Anesthetist will receive training if they are working in the obstetric department, they would receive, right? Because everybody who can attend and help in this situation will help, right? Okay, so do you think that shoulder dystocia training only can be run by doctors, obstetrician? If you do have experienced or a coordinator midwife, can she participate in the training? Yes, she can, right? Yes, if she received the training of trainees, yes, she can. Why not? Correct? Okay, so that's why it's a multi-professional. The RSV vaccine administered during pregnancy at? Nowadays, they ask questions about the RSV, about all vaccines, actually. "28 weeks, yes. Yes, okay, good. So this is from the information about the vaccines in the pregnancy, okay? And should be offered around the time of 28 weeks at the antenatal appointment, okay? People receive vaccine also for whooping cough, right? Yes, the whooping cough is a pertussis vaccine, okay? Flu is also advised for everyone. Okay? Yes, my dear. Okay. So now you would remember RSV, right? And this vaccine will reduce the risk of the severe bronchitis by 70% in the first 6 months of life. Okay? And the whooping cough, the pertussis vaccine, and the flu vaccine. The flu vaccine will be given at the seasonal time. Okay? So anybody can receive it, but at its time. And usually would be the starting, before the starting of winter. Okay? It is safe. A woman with gestational diabetes have been given birth 12 hours ago with the help of forceps. She is breastfeeding and she is very anxious about the prospects of her baby developing hypoglycemia. The woman is aware of possible need for blood test on her baby and ask about cut off of the baby blood glucose, which would indicate risk of neonatal hypoglycemia. That's very easy. So please tell me. Yes, the 2. Yes, exactly. 2. So the preprandial glucose for the baby would be 2. They still like the neonatal care, okay? After diabetes, they ask questions for the infections, by the way, like mother who received antibiotic or did not receive antibiotic for group B, streptococcus, right? What you will do in the follow-up for the baby. They ask questions about the herpes, okay? And how would you take care of the baby for a mother who had herpes during the delivery? So please, okay? Also, of course, HIV. So please, whenever you find care of a neonate in a guideline, revise it, okay? Part of your curriculum, right, is the neonatologic problem, the postnatal problems in the neonates. Why? Because you are delivering those neonates and you should be aware, right, that there is risk of the mother and what should be taken or what should be done for this neonate. Okay? For every level in the diabetes guideline, it's a must for your exam. Control before conception or control during the pregnancy, level of glucose during labor, what you will do after delivery or the levels for the women who have GDM and you wanted to test the hair, fasting blood glucose, what is the values indicate, this is all important, okay? So whenever you find a value in the diabetes guideline, it's important. What is the ideal induction regimen for a patient who is IUFD at 26 weeks? So they bring one question from the IUFD guideline. Single 200 milligram dose of mifepristone is appropriate for this indication, followed by, if you are speaking about 24 to 24 plus 6, it will be 400, right? Buccal or sublingual or vaginal or oral misoprostol every 3 hours. If you speak between 25 to 27 plus 6 weeks of gestation, then 200. Also, all preparation is there every 4 hours. From 28 weeks of gestation, then it's 25 to 50 micro every 4 hours, or 50 to 100 micro every 2 hours, oral every 2 hours, okay? So the values, according to the gestational age, misoprostol level is important, okay? This is a new guideline or a new update of this guideline, so it was expected, of course, to have a question about it in the exam. What proportion of patients are asymptomatic following obstetric anal sphincter? Women would be advised that 60 to 80% are asymptomatic 12 months following delivery and the obstetric anal sphincter repair, right? Yes. Still, they like asking the resuscitation, blood resuscitation in cases of bleeding, and they love it, right? Patient received 4 units of packed red cells as part of ongoing management of postpartum hemorrhage. What is the next step in hair management? 4 units of packed red cells, followed by fresh frozen plasma. What is the dose of the fresh frozen plasma? You can give 12 to 15 ml per kg until the hemostatic test results are known. And what is the thing that can guide you as well? So you can give after 4 units, right? Or if he give you the value of PT, APTT more than 1.5 times of the normal, right? While the hemorrhage is ongoing. In this case, I must give, okay, the fresh frozen plasma. I even may increase this level, okay, if the bleeding is ongoing. But at least you remember 12 to 15, okay, roughly. And what are the conditions where I can give the fresh frozen plasma even before the test result come or before completing the 4 units? Why not C? Okay, because it's in the guideline clearly was mentioned about the exact dose. So I would give the exact dose better than the rough dose. Right? Correct? So, which condition, my friend, will you consider replacement of the fresh frozen plasma early? This is when you think that there is consumption of the coagulation factor. Like what? Okay, like the DIC, IUFD, abruption. Yes, well done. Well done. Okay. Would I still give, look, my dear, if you do have deranged test result, okay, and the bleeding is stopped now, and you left it untreated, what will happen after few, maybe few minutes or even a couple of hours? Like, for example, I give you a patient with APTT 0.1.9 of the normal time, okay? Times of the normal. And the bleeding stopped now. What will happen after this? The bleeding will continue. So once you do have indication of the repairer, or the replacement, you will replace, okay? Right? So you do have a patient, for example, okay, with platelets 25, and she stopped the bleeding. Will you leave the platelets 25 without replacement? No, right? Okay. So the trigger for the fresh frozen plasma is APTT or PT more than 1.5 times of the normal, right? Okay. And if the hemorrhage is ongoing, maybe you will need to increase or exceed, right? Okay. What is the trigger for the platelet? 75 is your target, right? And you need to maintain, right, the platelet count always, okay, 50, above 50 in acutely bleeding patient, okay? No, my dear, okay? It should be above 50, but 75 will give you safety margin, okay? So my dear, you should maintain it even if the patient acutely bleeding above 50, okay? And 75 is recommended. Why? To give you margin of safety, right? Okay, the platelet should be group compatible or not? Yes, ideally would be group compatible, RH negative, okay? So, how about the fibrinogen level? When you will give the cryoprecipitate, the values, you should know it by name, okay? Maybe you forget your name, but you don't forget this table. The cryoprecipitate standard dose of 2 5-unit pools should be administered early in major obstetric, right? Hemorrhage. And subsequent transfusion would be guided by what? By the fibrinogen result, right? What is your aim? Aim to keep the fibrinogen level more than 1.5. Yes, my dear. If the bleeding is ongoing, you would give over, but what is your aim? You must keep the fibrinogen level of more than 1.5. Here, the fluid therapy and the blood product transfusion, I am not joking. You are allowed to forget your name, okay? But don't forget this table. And if you don't know this table by heart, don't go to the exam, okay? I don't mean to actually frustrate you, everybody. You do have time to revise this one, okay? Because you will be required to do the calculation in the exam. I'm telling you why this is a must and you can't leave it. I'll tell you. You know, questions in the exam are equal or not? True or false? Equally distributed for marks. True or false? No, not equally transferred. No, yes, of course. So means that there are some questions that have higher value, right? Yes, I told you earlier and I'm telling you again, okay? So my friends, this is how your curve will go with every question. Up and down, up and down, up and down. If you have up, you will stay up, right? Okay, I'll tell you what is the curves of other, because everyone attending the exam has its own curve, and after all, they are comparing all the candidates together, right? So, you know, for the equally distributed questions, things will be easier. But for this exam, no, not equally distributed. And this is for a reason. They can't ask a question, for example, in management of autoimmune disorder, for example, okay, in pregnancy, or management of sarcoidosis in pregnancy. They give it, for example, 0.7 of mark, okay? But management of acute postpartum hemorrhage, they would give it 2 marks instead of 1. And they have all the right. Another question about, for example, okay, a new technique in the robotic surgery, maybe will have 0.3 mark in the exam. But a question about shoulder dystocia would have 2 or even 2.5. So if you are wise, okay, you would secure the basics of your specialty, right? The subspecialty is not that much important as the same. So someone expected to pass part 2 MRCOG and he is at the level of ST5, means that very soon will become a consultant, right? Doesn't know how to manage postpartum hemorrhage. Is that acceptable? I love you all, but if you did that in the exam, if I have the decision, I wouldn't let you pass. Right? Go again and study obstetric, please. Be a safe doctor before you become a member. Correct? So, think that mistakes are not acceptable at it in the exam and would drop you, believe me, okay? So somebody is doing like this, like the red person here, okay? And couldn't manage obstetric emergency, believe me, you will be here in the curve. This is how your curve will move. So with every question, you should be up, 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 up in the curve. The question that maybe affect your curve like this, okay, is the maybe sophisticated questions or difficulty questions. Comparing to others, everyone will get the same, so it's no problem. But if there is a basic question, everyone is going up, 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 and you are the only one who did it wrong, okay, this is how you will be in the curve. Okay, so you will have a drop in the marks. And remember, the marks that you get or the percentage that you get in the exam is not actual marks. This is your place on the curve. Okay, have you studied standard deviation? Okay, so yes, okay, so they would take 1 or 2 of the standard deviation in the exam. Usually they would take up to 2. And they will let the others. Thank you very much. See you next time. Okay, so it doesn't matter really what is your mark, your actual mark. What matter really is your place in the competition, your place on the curve. Okay, so things like this, mistakes like this will drop you very much on the curve. All obstetric emergency is a must, especially management of postpartum hemorrhage, shoulder dystocia. Okay, things that came repeatedly, you can't let it in the exam. They bring this table in every exam. Have you ever heard about any exam without this table, the blood transfusion and management of postpartum hemorrhage? No, never. Okay. Okay, so my friends, cryoprecipitate will administrate 2 pools of cryoprecipitate if hemorrhage is ongoing and fibrinogen less than 2. Correct? 175, right? Fresh frozen plasma, you would give the dose 12 to 15 ml per kg. If hemorrhage continues after 4 units of red blood cells and the hemostatic test unavailable, okay, you can give 4 units roughly of the fresh frozen plasma. But, okay, if you have to choose between the 12 to 15 or the 4 units, you go for the exact correct dosing. Okay? Patient being managed for ongoing postpartum hemorrhage have been transfused baked red cells and fresh frozen plasma. Her labs show platelet 75, fibrinogen 2.3. What is the next step in her management? Okay, so I'll tell you, my friends, the component that you can add, right, is either, right, the cryoprecipitate right? Or the fresh frozen plasma. Platelets, no use if the platelets already is 75. This is a safety margin. You are okay with this. Okay? So now he tell you that patient received the correct amount or the blood, red blood cells, and the correct amount of fresh frozen plasma. If he tell you this and it was the correct amount given already, so in this case, I would give the cryoprecipitate. It will help, okay? Prevent the further bleeding, right? Because when the fibrinogen is below 3, and especially below 2, would be associated with progression of bleeding again, right? So think of fresh frozen plasma or cryoprecipitate. If the fresh frozen plasma given by the correct dose and is still fibrinogen less than 3, then you can give cryoprecipitate, okay? I remember this question very much, Dr. Ahmed, because we have done a lot of research for this question, and your friend in the exam told that the fresh frozen plasma was given as a correct dose. Okay, but believe me, if the fresh frozen plasma was insufficient or given less than the correct dose, give. Okay? Okay, dear? If it's still ongoing bleeding, this is why I'm saying, okay, my friends, this question, because we had so much discussion about it, right? It was in the previous exam, not in this one. And I think it was also came before the 24 as well, okay? Your friends, what they said about this, okay? If the patient have received the correct amount of the packed red cells, okay, like 4, and she received, okay, that correct amount of the fresh frozen plasma. Let's say, for example, patient weight 70, okay, and the patient received like 1,000, for example, okay? There was option of factor 7A, good. So the question here, can I give 7A? Yes, I'm with you. I'm just asking you, would you give factor 7A? Okay, so you would give one of the blood components that are missing, correct? Yes, okay. So your first one of the replacement would be of the blood component after the IV fluids would be the packed RBCs, okay? Patient received the packed RBCs, then I'm fine. Patient have fresh frozen plasma, received the correct amount, okay. Did he give you something in the values of the exam that indicate whatever she received is not enough? No, okay? So what I have platelets and I have fibrinogen, okay? All ideal, good, Okay, so what is a component that I will give in this case? Now he give me 5 options, is to give fresh frozen plasma, cryoprecipitate, 2 pools of platelets, 3 pools, 4 pools of platelets. This is the options. Okay, so the only thing that can still be given in the cases is the cryo. Okay, we don't have any other option, right, that can be fit to this scenario. And because this fine detail in the guideline, when they tell you that the fibrinogen below 3, okay, and especially below 2 associated with progression of bleeding, okay, increased RBCs and the blood component requirement and the need for invasive procedure, okay? Yes, it should be maintained above 2. Look, my dear. Here, this is from the guideline, okay? During continuing postpartum hemorrhage, cryoprecipitate or fibrinogen concentrate should be maintained to keep the fibrinogen level at least 2, okay? Even if the PT and APTT normal. Okay, fibrinogen loss can be replaced by the cryoprecipitate or fibrinogen concentrate. Although fibrinogen concentrate is not licensed for acute hypofibronemia in the UK, okay, so this is similar clinical outcome, and the increasement in fibrinogen has been reported for cryoprecipitate and fibrinogen concentrate, but these are based on limited data. It is expected that 2 pools of the cryoprecipitate, okay, would increase the fibrinogen level about 1. Increasing the fibrinogen level by 1 require about 60 in the concentrate. There is observational study to improve the clinical hemostasis and possible related event associated with infusion of fibrinogen, okay, but still RCTs are required. Okay, so what do you want as answer? Yes, it's ongoing bleeding. What do you believe that this is the best one? If he give you one, okay, if he give you, look, my friends, okay, if he give you one value that is deranged, then your life is easy, okay? Then your life is easy if there is deranged value. Like, for example, if he give you that the platelets is 70, okay, what you will give? You will give 1 pool of platelets, even not 2 or 3 or 4, like the options, right? Yes, only 1 pool is enough. Okay, so I would do. Why not? So I have comment from Doom user. Are you sure that in the exam it was 70? Actually, things will be much easier if it was in the exam 70. Actually, what is my aim? One pool? Okay, I would give one pool. Why not? Yes, Dr. Ahmed, if this was in the exam, then I'm happy to do this. Okay, guys, if the platelets is less than 75 and you have option of one pool, this will be correct one. Of course, I would give it. And things will be much easier. Yes, so thank you. Yes, there will be no problem now and no fuss, by the way. So thank you very much that you corrected the concept. Yes. Okay. Yes. So guys, your friends now. Yes. But still options there, okay, that to give something. There is no option that just watch the patient. That's because of the ongoing bleeding, right? So if the ongoing bleeding is still there, okay, means that you will still do something for the management, right? If the platelet is less than 75, give platelet. Okay? So that will be very easy. Thank you very much. Yes, much easier, alhamdulillah. I wish I met you before, my friend. Zoom user. Thank you. What is the recommendation for screening for GDM in women with history of PCOS? Why screen disappear? It's there. Question 31. If the woman have PCOS, okay, what you will do for the screening? Look, my friends, who is the only person that you will screen at booking? Look, my friends. I don't care about the Monash, my dear. I care only about the NICE guideline of the diabetes. Okay? Look, my friends, assessment of the risk for gestational diabetes using risk factor in healthy population. Okay? And this will be done at the booking time. Check for the risk factor. Check for the risk factor. For BMI above 30, previous macrosomic baby 4.5 or more, previous gestational diabetes, family history, okay, like first degree. In this case, if the woman is the OGTT in the second trimester, right? So you assess at booking, but you will offer the test when? In the second, okay? So high risk only will be in the second trimester, correct? But for the women who have gestational diabetes in the previous pregnancy only, okay, what you will do, you will either offer early self-monitoring of the blood glucose level, like a blood sugar profile, okay, or OGTT as soon as possible after booking. And further, OGTT at 24 if the first one was normal. Clear, my friends? So I have only previous history of GDM that make me go for OGTT at booking. Clear? So for any other condition with high risk of diabetes, what you will do? At second. Okay? Because the RCOG and the UK practice, my friends, are different to other organizations and other countries. They don't provide OGTT for all patients. Some places, they provide OGTT for all. And they have the reason. Like, for example, maybe high prevalence of the disease, right? But for the UK, it's only assessment of risk at booking. And if the woman is high risk, OGTT at the second trimester. Okay? Here, this is from the GTG. Prevalence of gestational diabetes is twice as high among women with PCOS compared to control group. Clinician may consider offering to our post-75 oral glucose to all pregnant women with PCOS, similar as for screening in women with any other risk factor of gestational diabetes. Okay, so when this will be done? No, I don't follow ISHRI. ISHRI is not a UK guideline. Don't leave two UK guideline, okay? NICE guideline and GTG guideline and follow ISHRI for this exam. This is MRCOG, right? Do you know what is the ISHRI? Guys, ISHRI is abbreviation of what? European Society of Human Reproduction and Embryology, right? Is that a UK society? Is that a UK guideline? No. So is that my first source for the exam? No. So the rule says if you do have a clear UK guideline, national guideline, you follow it, right? It's the MRCOG. You wanted to be a member of the Royal College of the UK, right? So what you will do is that you follow them, okay? They don't do the screening at booking for PCOS, then finished, okay? During ongoing hysteroscopic procedure with sorbitol as distension medium, okay? So the hysteroscope guideline, right? And the surgical management as well, okay? Now you have fluid deficit of 1,475. What is the appropriate management for it? This is dangerous, right? What is the problem of the mannitol or sorbitol as a distension medium, also with glycine? They cause a very serious side effect, which is the hyponatremia, hypervolemia, right? What will happen if not treated or continued? Bradycardia and hypertension, right? Followed by pulmonary edema, collapse, and death. And there are cases reported of death because of the fluid deficit, okay? So now I have this number, 1,475. I would stop the procedure, right? Yes. Okay. Management of hypervolemic, suspected hypervolemic, hyponatremia, when the fluid overload above 1,000 with hypotonic distension media. What you would do? Actually, you would do, for patient who have asymptomatic hyponatremia, fluid restriction, okay, less than 1 liter a day, and loop diuretics, okay? Symptomatic hyponatremia will be hypertonic solution, 3% saline, okay? Supplementation of oxygen, indwelling catheter, high dependency care unit, and MDT involvement. Please be careful. The point of management of hyponatremia came recently, okay, as emergency case in the part 3. Means that this will be a site of your exam question in the January exam, okay? Expect that you would have another question of it in this next one, okay? Surgery would be immediately stopped when the fluid deficit is 1,000. Repeat what I said, okay? If you have, believe me, I'm so sorry. Guys, there was internet connection problem. If you have deficit 1,000, immediately stop. Oh my God, I'm so sorry. Okay? So here, will you stop the procedure? How to treat hyponatremia? It's considered as an emergency, and you would expect a question about it. Okay? Why? Because it appeared in the part 3. So acute hypervolemic hyponatremia. When you have asymptomatic hyponatremia, 120 or more, okay? Fluid restriction, like less than 1 liter a day, and loop diuretic. If it is, okay, if it is symptomatic, less than 120, hypertonic solution, okay, with NaCl, okay, supplementation oxygen, indwelling catheter, high dependency care, and MDT approach, okay? Okay, so it's stop immediately, okay? There is nothing like you complete the procedure quickly or something like this, no, okay? Here again, stop procedure if fluid deficit reached 1,000, hypotonic solution like mannitol, sorbitol, okay? If the patient is elderly, we consider this from 750 as well. Or if the patient have comorbidity. So even this 1,000 will be, the threshold will be lower, 750, if the patient is elderly or comorbidity. Okay? If it is isotonic solution, okay, then isotonic solution will be 2,500. So be careful of what solution given to you in the exam, okay? Okay? Clear, my friends? The cutoff is important. By the way, this is not the first time this appeared in the exam. It was there July 2024. Okay. So what is the statistical method to compare mean birth weight among the two groups of pregnant women and without preeclampsia? Student t-test. Types of tests still comes in the exam, and it's important. What is the statistical method used to compare the mean arrival time between one-stop gynae clinic versus the postmenopausal bleeding clinic? So look how kind is Dr. Melenji. She prepared for you the types of variable again between the categorical or the continuous numerical, okay? And here for the test, parametric test and non-parametric test. Then for each test, okay, what is the use of it? So like chi-square, okay, test of independence, or one sample t-test, or independent sample t-test, or paired sample t-test, or ANOVA, or Pearson correlation, okay, Spearman, or regression analysis. Okay. Epileptic patient on lamotrigine came for her routine antenatal care. She's non-compliant on the medication. She threw a fit during her visit, which lasted for 6 minutes. What is recommended management? Patient who had routine antenatal care. For any seizure lasting more 5 minutes is considered unusual. Okay? This could be a life-threatening emergency. And the treatment would be initiated, okay, immediately, right? Of course, you have to do the left lateral tilt, right? Maintain the airway and oxygenation all the time, right? So patient was in the clinic waiting area. Okay, good, my dear. There was any option for initial resuscitation or stabilization, Dr. Fatima? She came for clinic, ma'am, no IV line. Okay, good. Yes, no IV line. I agree. Just medication. Good. I would give the diazepam as well. Okay? I would give the diazepam as well. If the patient have intravenous access, okay, then the lorazepam will be given as intravenous dose, right? But the question is, this is for people who attended the exam. If there was any mention for the route of the medication or just the name of the medication? Many routes were there. Okay. So would you please mention anything about the routes available? I think if you do have a lorazepam IM, this would be great. Did you have a lorazepam IM? So now people say, oh, routes I'm there, and somebody says that means arrange a step. Okay. If routes choose, no route to choose. Let's say right answer and move, doctor. What do you think? Okay. Look, my dear, it's about, okay, what was the option, okay, that is available. That's it. Okay. So if the option have no roots, okay, I would choose the diazepam, to be honest. Okay. I would choose a diazepam if there is no roots. Because the diazepam, you do have different, you know, roots for the diazepam actually. Okay, so I would go for the diazepam. Diazepam can be given both IV and per-rectal. Lorazepam mainly will be given as IV. Okay. Okay, then go for the diazepam, please. Okay, since no options are there, you can go for the diazepam. Okay, so if no roots are not there, go for the diazepam. My friends, what is the type of inheritance in this disease? Yes, of course. Okay, so the one that skips generation, this is the autosomal recessive. Yes, good. Patient present with florid vaginal discharge, 8 weeks. Partner recently treated for gonorrhea. She had a known allergy toward the coamoxiclav. What is the appropriate management? What you will do? Okay, so what is the recommended management for the patient? If you do have a confirmation of the infection, right? You can give the azithromycin, right? Or erythromycin or amoxicillin, right? In pregnancy, you do have a choice for any exam, okay? Between azithromycin and erythromycin, which one you go for? So the one that is fully studied in the pregnancy is the erythromycin, okay? The one that is fully studied for pregnancy and it is safe, it is the erythromycin. Azithromycin in the pregnancy, they said that not proven to cause a problem, but in the same time, still more study needed. Okay? So if you have to choose between two medication, you will go for the erythromycin, okay? But the patient have allergy towards the coamoxiclav, are you sure about it? Okay. No, it's not because of the macro lead resistance, my dear. You know what? It's one second, my friend. Okay. One second, my friends. Thank you for keeping you waiting. Okay. Look, my friends. Here, what we have about this case. If you wanted to do confirmation of diagnosis of a disease, okay, what you will do NAT testing, right? Right? Okay. So the NAT testing, this is a recommended diagnosis, okay? Otherwise, if you compare the NAT to the culture, you will find that the NAT is more sensitive and more specific, right? Okay. If you want to treat a case by appropriate treatment, okay, you do have ceftriaxone, right? What is the dose of the ceftriaxone nowadays? Because it was 250, it was 500, and then now it become 1 gram. Yes, it's 1 gram. It is a single dose or it's a repeated doses? It's a single dose, right? Good. So this treatment by the ceftriaxone intramuscular as a single dose can be safe in pregnancy or not safe? Yes, it is safe, right? Okay. So what do I have as alternative regimen? Okay. This would be, okay, that cefixime, a single dose plus azithromycin, gentamicin, intramuscular plus azithromycin, spectomycin, okay, plus azithromycin, or azithromycin as a single dose, but the clinical efficacy of azithromycin does not always correlate with the susceptibility testing. Why? Because the rate of the azithromycin is actually high nowadays, right? Okay. So when you would do dual therapy with azithromycin when you have pharyngeal infection, okay? But our patient here, she had a vaginal infection, okay? So now about the exam. If you give me in the options, option between testing and option between treatment, okay? You will go for treatment, okay? Yes, if you do have two things between, no, for this particular patient, why is this particular patient in that question? 1 second, and go back to the question. For this particular patient, my friend, Okay, this patient, what is the thing about her? Yes. Okay. So did she treat it? Is a partner treatment is recommended in the cases of gonorrhea or no? Yes, it's recommended. Okay. Is she treated? If the patient herself is treated? No. Anybody offered the head? Did he mention in the exam that this patient was treated or anything? Okay, 1 second, my friends, because I'm still receiving feedback from your friends who attended this same exam. Separate question, mashallah. Okay. So 1 second. One says, one question for investigation and one for the treatment, not combined. Mashallah. Okay, good. 2 questions on gonorrhea in the exam. Oh, really? A lot. Okay, good. That's okay. Thank you for letting me know. Look, my friends, let's say I have the same question. Let me answer the same question, my friend. Okay. First of all, for the partner, treatment of sexual partner of gonorrhea, if the partner is a continuous exposure partner, like husband, okay? Like husband. And this is within 14 days of exposure. So this is 100% with continuous exposure. What you recommend, epidemiological treatment, means that the ceftriaxone one. Okay, so the patient married to someone have gonorrhea, recently treated for gonorrhea. She's coming to you with symptoms, okay? And she's pregnant. Time to test or time to treat? It's time to treat. When I will consider testing, I will consider testing if she had exposure, right? After 14 days, right? While I don't know, okay? Right? She's now coming to me with symptoms. She's not even a silent partner, okay? So I would give the epidemiological treatment, right? This is what I'm thinking of in a patient who have partner, okay, is treated for the gonorrhea. That's why we're all thinking about the gonorrhea, right? That's why we are all thinking about the gonorrhea. So partner treatment of sexual partner, yes, I would treat, okay? So let's say, like your friends now just added for this question. Let's say treatment was a question, testing was a question. I will tell you. Testing is very easy. Testing will be by NAT testing. Okay? Correct? Yes, NAT will be the one. NAT will be the testing. What about the treatment? Treatment, I will give ceftriaxone. right? She had problem with the coamoxiclav. Okay, it's not my problem at all. Coamoxiclav is not my option. I do have either the ceftriaxone or going by the azithromycin. Azithromycin is not preferred because of the high, resistant one. Clear, my friend? Okay. Happy so far? Any questions so far? This is like a summary, okay? For the best test for each one, gonorrhea has not, is the best, okay? It has endocervical discharge, and the best treatment or the first line of treatment will be the ceftriaxone, okay? Don't overthink, my dear, okay? So, if he tell you that there is cross-reactivity, then it's okay. Otherwise, didn't mention about even, okay? What is the level of the? Yes. Okay. Okay, friends, clear? This is a recall one, my dear. Okay, alhamdulillah. Okay, good. I want to cover at least the 50 SPA before the break, to be honest. Okay, because then after that we can do some cues. How to ascertain fetal well-being during laparoscopic appendectomy done electively for a woman at 25 weeks of gestation. General anesthesia, my friends, carry risk to both pregnant women and baby, right? It's actually 17-fold higher, okay? To avoid the aortocaval compression during the surgery, you have to do a left lateral tilt. But this is to what? To avoid the aortocaval compression, right? Avoid uterine or cervical manipulation. Limit the intra-abdominal pressure to less than 12. No evidence for giving tocolytic agent for prophylactic during the surgery, right? Fetal heart rate monitoring should be conducted pre and post-operatively once the fetus is considered viable. This is from 24 weeks of gestation, if possible, okay? The fetus during the surgery would be monitored if possible. However, this is only useful if there would be an intervention in the case of non-reassuring fetal heart rate pattern. If adequate maternal oxygenation and uterine perfusion are maintained, the fetus should be tolerate the surgery and anesthetic very well. Okay? Guide about the continuous monitoring. Okay, actually, I haven't seen a continuous monitoring by CTG during surgery. But here you wanted to make sure that the baby is enough. baby have enough oxygenation or baby have enough perfusion, what you will do? If you want to check you can check just by the ultrasound, okay? A probe of ultrasound from the other side and have it, but this is would even disturb the anesthesia, okay? Otherwise, this is not recommended unless you have a problem, non-reassuring fetal heart rate pattern, okay? So you make sure that mom is well oxygenated. So means that ensuring the maternal oxygenation and uterine perfusion, okay? Okay. Yes, I would go for D because I don't have any other method actually for a continuous monitoring. This is how to ensure that the baby have enough oxygenation. So how you will ensure that the baby is good? Mother is good. Okay. Patient underwent laparoscopic salpingectomy for ectopic pregnancy. Her blood loss was estimated to be 1500, BMI 31. What is the recommended VTE prophylaxis? Answer for what? Okay. Ten days. Okay. What is the recommended VTE prophylaxis for a patient who had DVT following a previous orthopedic surgery? Now coming for booking. That's very easy. So if the DVT is provoked, what you will do? Prophylactic, consider the prophylactic from 28 to how many days? 6 weeks postnatal. Yes. So I would give the prophylactic from 28 to 6 weeks postnatal because it's a provoked. Yes, Dr. Dania, correct. Provoked? No, my dear. Look, unprovoked means that's a hormonal related reason. Provoked with surgery. Okay? So you can simply look here. This is related to surgery. So related to surgery, risk is only 3. Okay? Scoring is 3. Okay, dear? Make it easy for yourself, okay? Anything but surgery will be considered for the whole pregnancy, score 4. But if it is related to surgery, score 3. Okay? Related to surgery is a score 3. Other reasons, okay? Even they wrote in the guideline, not related to surgery, okay? What is the recommended VTE prophylaxis for a patient aged 30, delivered vaginally following 24 hours of labor? Her estimated blood loss during labor is 800. Age 30 is a risk? No, not risk. She delivered what? Vaginally, okay? Labor for how long? Prolonged labor more than 24 hours. 24 hours itself, what? Prolonged, no means that more, not at. Okay, so if you mention only 24 hours, this is not a prolonged, okay? This is the prolonged labor here in the table. It's 24, more than 24, okay? So what is the blood loss? 800. Is 800 a risk? No, okay? So what I will do for a patient who have low risk, a lower risk patient is early mobilization and avoidance of dehydration. Okay? Early mobilization and avoidance of dehydration. Okay? Okay, good. Family history of VTE, what is provoked? Family history of VTE, this is one. Okay? But it's according to what is a reason of the family history VTE. Okay? Cholestasis take, what cholestasis, my dear? I can see many questions that not related to the question here. So let's complete our scenarios and then we focus. What is the recommended VTE prophylaxis for patient aged 35? Okay, so age 35 is a risk factor or not? Age more than 35 is a risk, but 35 itself, no. Okay, mid-cavity forceps is a risk or not? Yes. Okay, delivery by a mid-cavitary forceps is risk or not? Okay, blood loss is 1800. Mid-cavitary, rotational, or operative delivery. Okay. Okay. So how many risk factors here? 2. What is your recommendation for this patient? Low molecular weight heparin for how many days? For 10 days. Right? Good. What is the management of simple ovarian cyst measuring 6 cm in postmenopausal woman? And risk of malignancy index is less than 200. So since it's 6 cm, I have to do something, even if the risk is low. If the risk is low, means that I'm not going to refer to MDT, but can be managed in the hospital. Yes, bilateral salpingo-oophorectomy. Well done. Which of the following are associated with interstitial cystitis? So medication that can cause symptoms like interstitial cystitis is ketamine. Yes. Yes, it's called the ketamine cystitis. Bladder will be ulcerated and fibrosed. What other medication that can cause the same is cyclophosphamide. Following risk reduction surgery due to BRCA1 carrier status, a 35-year-old with past history of breast cancer, no current medication, experience troublesome hot flushes. What are the recommended management strategies? Hot flushes, and she have risk reduction surgery for BRCA. Past history of breast cancer herself. Okay, or yes, salpingo-oophorectomy, breast cancer, no current medication, so she's not on tamoxifen or anything. She complained hot flushes. So HRT for a woman who have personal history of breast cancer is not preferred and not routinely recommended, especially if the patient is estrogen receptor or progesterone receptor positive breast cancer, right? Yes, only BRCA without personal history still can use. Okay? Only family history, okay, can still use. Okay? Okay. This is because we couldn't offer her the HRT because she had personal history, okay? And it's good, it's licensed actually for control of hot flushes. Okay? So I have one, okay, that is mentioned for the hot flushes. Why to leave it? Personal personal history is a problem, Dr. Dania. Okay? Yes, I can still give. Yes, my dear. Okay? So the question here is a patient, okay? By the way, never ever, okay, advise SSRI for hot flushes. Is not related, okay? For hot flushes, why you will give SSRI? Yes, this is related to the mood problem. The question here, okay? Can I give SSRI for a personal history of breast cancer? Okay, so he said he helped you in this situation and he mentioned what is the problem? He mentioned the hot flushes only, right? Okay. What he mentioned about the medication, he said she's not on a current medication, but she had a breast cancer, right? For patient who had a breast cancer, personal history of breast cancer, can you give HRT? No, the answer is no, right? Even if there is some exception in cases, this is not your job at the part 2 exam, right? Easy so far? BRCA itself, is a BRCA contraindication for HRT? No, BRCA is not a contraindication for HRT or hormonal. A BRCA status itself. Okay? So the positive thing in this patient that she had breast cancer. She herself had breast cancer. You see hot flushes, breast cancer, go clonidine, okay? Here for the newborn, resuscitation. Now become one of the skills that you must ask in the exam. If you didn't find it in the part 2, you will find it in the part 3. What is the ratio of delivery of compression and ventilation in a minute? 3 to 1. Yes. What is the gold standard for diagnosis of MRKH? MRI. Yes. Mother brought her 16-year-old daughter for MRKH, or she had MRKH, I don't know. She inquired about the suitable reproductive option for her daughter. Why MRKH? She had ovaries or she doesn't have ovaries? She have ovaries, right? Yes, the patient have ovaries, correct? She had absent uterus, right? So what she need? She need the uterus, okay? She need the uterus, okay? So means that host surrogacy, okay? Yes, will take her own eggs, yes. Patient was planned for vaginal hysterectomy. Her hemoglobin is 10. What is the appropriate management? Hemoglobin 10. Will you transfuse blood? IV iron? No, oral iron is enough. Okay, what is the rate of persistent trophoblastic disease following salpingotomy? Yeah, old question, very old one. Okay, so my friends, now we deserve a break. Okay, so we can have a break and we come and discuss some of the EMQs. Will that be okay? There is no other new SPAs in this exam. Okay, so if you did already the previous exams, you will find that the SPAs are very common, the remaining one. Okay, but just have a look to the EMQs together, my friends. Yes. So we will have a break and continue, okay? 10 minutes until you make something hot to drink, or people who want to pray, they can pray and come back. 10 minutes. Okay, thank you very much. Yalla break, okay. Thank you. Okay, we'll come back with the EMQs. Okay, friends, so let's have a look here. This is a POPQ. So what do you think the problem is here? For the POPQ, we all know that the point AA, what does it represent? It represented the anterior vaginal wall, right? And when the point AA comes with a positive, means that what we have a stage of the prolapse from 2 plus 1, right? Okay, maybe 3 or maybe 4, right? So this will be according to the total vaginal length, and if you have a stage 3 or 4, surgical correction will be required, right? So what type of the surgical correction? Is it repair with mesh or without a mesh? Of course, without mesh. Okay, so yes, correct. Yes, correct. Here, one question. This is about a patient who presented 8 weeks of gestation with complaint of abdominal pain and bleeding. Ultrasound show intrauterine gestational sac corresponding to 8 weeks. Fetal cardiac activity present. Subchorionic hematoma measuring 3 to 4 of the gestational sac size. 2 previous second trimester miscarriage. What is the appropriate management for her? So a patient with threatened miscarriage, how you will manage in presence of previous pregnancy loss? You will give progesterone. What type of progesterone? You will offer the vaginal micronized progesterone 400 How many times per day? 2. Yes, until 16 weeks. Yes, well done. Gravida 5 recently came to know the gender of the fetus as a male. She wants to proceed with the termination. She claims that she doesn't want any more male children since she had 4 boys. What is the law respect? No. Yes, this is illegal. Yes. Okay. So the only reason for gender selection or for avoiding male, for example, babies, that's because of the medical problem. But otherwise, no, not allowed, either girls or boys, no difference. So this is not under the Abortion Act. Yes. Patient is known to have rheumatoid arthritis. Abortion law does not comply with the Abortion Act because it doesn't mean, okay? No, Kunji is not your reference in this case, my dear. Okay? Because it's illegal nowadays in the UK. Okay? Okay? Yes. Is not covered by the Abortion Act. Okay, guys? It's illegal. Patient has known case of rheumatoid arthritis. Her disease was not controlled on methotrexate. Okay? Hydroxychloroquine and sulfasalazine. She was then put on the sertolizumab. Her disease is well controlled. She come for preconception counseling. What is the recommendation regarding the medication? The question here, okay, for the methotrexate, of course, this is where you will stop, no problem in this. The question here is, can I continue with the sertolizumab or not? What do you think? Okay, sertolizumab can be continued the whole pregnancy or it must be stopped. It can be, right? Okay, can I give the sertolizumab in the breastfeeding? It can be given in the breastfeeding. Okay? So here you can see, okay, for the summary of the medication. Okay, for the sertolizumab here, can be given preconception? Yes. Okay? And can I give it in the first trimester? Yes. Can I give it in the second or third trimester? Yes. Okay? Can I give it during breastfeeding? Yes. Okay? Yes. If the mother continued the medication in the last trimester, okay, so there will be some precaution for that baby. Like what? Like avoiding any live vaccine. Okay? Any live attenuated vaccine should be avoided for how many months? For 6 months post-delivery. Okay? Okay. Okay. Here is patient who is 15 or 16 years, I'm not very sure. She had learning disability, was brought by a mother, complained of heavy menstrual bleeding, tried the COC, which were recently withdrawn since she developed hypertension. Her mother came requesting for a levonorgestrel insertion. How will you proceed? Can be continued till delivery in severe disease, my dear. Okay. So why would I assess the capacity? Okay. If a girl is 15 years old, okay, would I take consent from her mother or from her? Okay. Hair's capacity is okay. Okay, good. Okay. Guys, 1 second. 1 second, okay? When I say somebody with learning disabilities, okay, means that this person is a special need. Okay? So, a learning disability is a nice name to describe people with a special need. Okay? Okay? Yes or no? Okay. This is one thing. Okay? Okay. So, this is not when he refer in the exam with a learning disability, doesn't mean that she has some maybe dyslexia or some problems in reading or something. No, learning disability means that she have a problem like autism, for example. Okay? This is one thing. So the girl, she have heavy menstrual bleeding. Okay? Okay. She is still a child or not? Yes. Okay. So can parent give consent or not? Yes. So the mother can still give consent. Okay. Yes. Yes. Okay. So here you will do as requested from whom? Without consent? No. Parent consent is sufficient in this case. It doesn't mean lack capacity, even if she have capacity. Okay. Even if this girl, she have capacity, will you take the consent from her or the parent consent is enough? Okay. So good. You wanted to assess the capacity, right? I agree. I don't want to say anything else. I just want to say here. Parent consent is sufficient? Yes or no? You need to explain the condition to the girl or not? Parent can give consent, but still you need to explain the procedure, right? Yes, you need to explain the procedure. So when he said that only parent consent is sufficient, can I agree for this? Mother can give consent, but this is not only. Okay, you get the point? No. Okay. Her parent can give consent. Will I give consent? I take consent from the mother and totally ignore the girl? No, right? So this sentence would be partially correct, right? So this sentence is partially correct because parent consent can work, but this is not the only thing that I will do. Okay? So here, take consent of the patient. I can take the consent of the patient if she's an adult, right? So I wouldn't do this now. Escalate to legal unit of the hospital. No, not legal point. When I will escalate to the legal unit, when only hysterectomy is there or sterilization. Yes, okay. If only hysterectomy or sterilization. Okay. Take consent from the legal guardian. Legal guardian is not there, mother is there, so no need. Take two doctor opinion, why? Take mother verbal consent, no, never. Okay? Yes, she is considered as a legal guardian, but I wouldn't call any mother as a legal guardian, right? If he mentioned or he declares that she is a mother, right? So my friends, now I have option D, to take consent after assessing mental capacity of the patient. Can I do this? Consent can be taken from the patient herself or from the mother. And most likely in this situation, I would like to assess the mental capacity of the girl. Why? To explain the procedure to her and know her opinion, right? And then, okay, I would take the mother consent. You get the point? Okay, friends? In the presence of parent, my friends, okay, we take the consent from the parent, but after explanation to the child. You got the point, guys? Presence of parent are there. I'm explaining the procedure to the child, right? To involve the child in the decision making and to know their opinion, right? I'm not going to ignore the child at all. Okay? But in the same time, paperwork, who will sign the paperwork? Mother, if she is there, she will sign, right? What about if this is a termination of pregnancy and mother is not there? If this is a termination of pregnancy and mother is not there, in this case will be assess the mental capacity and then take the consent from the girl. Correct? Yes, Dr. Ala, I didn't say to take the consent from whom, but I agree that we assess the mental capacity of the girl. It didn't say take consent from whom. Right? So that's, you know why I'm explaining this? Because you will never find it in the exam in the same words. You will find different words in the description of the question in the exam. Okay? Giliac is for mental capacity, Dr. Fatima. Okay? Father is the one that speak about the contraception and the termination of pregnancy. Okay? So when it comes to the assessment of the mental capacity, you will say Giliac competency. Okay? But the law that allows the teenagers, okay, to have their own decision regarding the contraception or regarding the taking step in the decision for pregnancy or something, this is the Fraser guidelines. Okay. So my friends, remember, for the below 16 years old, normally mother or father will sign the consent, but after explanation of the procedure to the girl. Termination of pregnancy is the exception. Another exception that mother or father is not there and no legal guardian. Okay? But normally still, this is the parent right. "21-year-old present with sudden onset of pleuritic chest pain, breathlessness. She also complained of a swelling and redness in the left leg." That's very classic question. So now the patient who have PE and she had pain in the leg. What you will do? She started low molecular weight heparin. The Dopplex confirmed the DVT on the left leg. What you will do? You will continue, right? Do you need any further investigation? No need, right? So just to continue the low molecular weight heparin. Gravid 3 presented at 14 weeks of pregnancy. She had history of second trimester loss in the first pregnancy and Schrittker stitch placed in her second pregnancy. She delivered at 29 weeks of gestation. What is the recommendation regarding the current pregnancy? So what did this patient? She had second trimester loss, right? In the second pregnancy, she had already stitch. And even despite of the stitch, she had a preterm delivery. Okay? So what I would do, forget about the what is highlighted here. What I will do, why would I consider progesterone after failed circulage? No, I wouldn't measure that. Guys, after failed, forget what is highlighted here. Okay? After failed transvaginal or cervical circulage, what you will do? What serial? She delivered at 29. Is that okay? Is that failed or not failed? Not failed. Okay. This is failed. Guys, if the patient had a preterm delivery after the circulage, what we call this? What we call this? What is the definition of preterm labor in your guideline? Which patient you consider she had a previous history of preterm labor? 24 or 34? 34, right? Yes, okay. So the patient who delivered at 29, are you okay with that? No, you're not okay with that. Okay, so if this is failed, what you will do? You will go for abdominal circulage, right? So I have seen here two answers. Some say B, some say D. Okay? Okay? So transabdominal circulage or Measure serial of ultrasound again. Okay, can I offer her the transabdominal circulage at 14 weeks or no? Okay. It can be offered from 11 to 14. Okay. Yes. Okay. Patient came for OGTT during pregnancy at 26. Junior clinic ask you about the following circumstances. Do we offer patient to screen for OGTT? When you will offer? What is the recommendation when you will offer a screening for GDM? Yes, 1 plus on 2 occasion or 2 in 1 occasion. Yes, well done. A 36 male came for evaluation of secondary subfertility. He has complaint of fatigability and was unable to to produce semen for testing. His hormonal profile show low TSH, FSH, and LH, hypo. Everything is hypo. He has fathered the child before. What is the next investigation? So if you have hypo and this is a secondary infertility, what you will do? Actually, I would like to do a hormonal profile, right? For hypogonadotrophic hypogonadism, right? I would like to do a hormonal profile, correct? What did he do till now? TSH, FSH, and LH. Prolactin not checked, so you do it. Good. Patient came with PPROM at 29 weeks of gestation. She had a Schritt-Car circulage in place in view of her previous pregnancy loss. She had no contraction. What is recommended regarding removal? So what is the guideline says for the removal? Okay, so before 34 weeks, can I consider the delay in removal or no? I would consider the delay of the removal when? To give time either for the neutral transfer or for the steroid to work. Right? Right? Okay. So look, my friends, it's a guideline recommendation, correct? So what we do with a guideline recommendation? We just apply it. right? As it is, right? Okay, so what the guideline says about it? Question was if you want to remove under what anesthesia. Good, 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 good. Okay, so I'm happy that my friends here attending, okay, who had experience with the exams, they can help us actually refine our questions. Okay, so look, my dear, first let's agree with the concept that for a woman who has PPROM from 24 to 34, okay, she had no infection, no preterm labor. In this case, I can delay removal of the circulage 48 hours to facilitate the in utero transfer, correct? Okay, the question here for the suture removal, right? Which anesthesia I would need? If it is a high, if it is a high circulage like the Schrödinger, okay, inserted with bladder mobilization, yes. The patient, no, I can't remove it under local. No. This is a high circulage, my friends. No, no need for GA. Why GA? Okay? I can remove it under a spinal anesthesia, or a regional anesthesia, but is not removed without anesthesia, is not, okay, is not removed with just a local one. I can't do it. This is a high. That's why they said here in the question, okay, and it makes sense actually, that they said for the Schrödinger circulage. Schrödinger circulage is a high or a low? This is the high circulage. What does the guideline say is regarding the removal of the circulage? They say that the high circulage inserted with bladder mobilization would usually require anesthesia for removal. Okay? And they didn't mention which type of anesthesia, but it should be under anesthesia. And it makes sense. If you have a pregnant woman, which type of anesthesia would you expose her for? You would avoid the GA, right? Actually, we do the GA in some circumstances, okay, where the patient is unstable or something, okay? Otherwise, for any pregnant woman, a regional anesthesia is much, much safer. We just said in the previous question, general anesthesia carries 17 times risk higher than, right? Yes, and it's actually general anesthesia for laparoscopic surgery, of course, because anyway, it's a laparoscopic, but this is for elective cases or if the mother is not stable, right? This is not a missed question, my dear. Just said about the risk of general anesthesia compared to regional during pregnancy. So it's 17 times higher risk. Was that in the exam questions, my friend? Intonox was in the exam question, or this is just a discussion for the purpose of discussion? No, I'm just asking my friends here who attended the exam, okay? Who said that the option was different. They said in the exams, and the option was asking about the type of the anesthesia. Okay, I would go for the spinal. I wouldn't go for any other type. Yes, if he ask me about the decision of delaying removal of the suture, I can delay removal of the suture for 48 hours if I need in utero transfer, right? In case no labor pain, no infection. This is the maximum time I can wait for. It's 24 hours. Otherwise, no need. The suture will be removed. Okay? If it is a Schrödinger circulage, you need anesthesia to remove it. Best anesthesia for a pregnant woman will be the regional. If it is a low circulage, not necessary to be under spinal anesthesia. You don't need it in the low. Low, we all did low in the labor rooms, and it's okay. So Dr. Mayada is asking, no time of steroid option was there. Why no time for steroid? Since the patient doesn't have labor pain, no problem. I'm not worried about the steroid in this case, my dear. I'm really worried about that this patient start on labor pain. Okay, so I would arrange for removal of the circulage. What the guideline says for the neutral transfer. Okay, so I'm explaining every Dr. Nada. See, I have two teams who attended the exam. Someone says this question was about the type of anesthesia, and another one says that this question was about the steroid. So I just give the information, and I'm not sure, actually, I wasn't there. We don't actually, I'm so sorry that you didn't pass the exam, my dear, but people, they they need the collective result, not only one question result, right? So still people can pass the exam while they have wrong questions, right? And vice versa. In this case, you will be, my friends, in this case, you will be guided what is the needed. Okay? If he asks you about anesthesia, choose the anesthesia type. If he asks you about waiting for 48 hours for the neutral transfer, okay, or what is the best decision making, like the scenario, okay? So for example, he can say, for example, that this patient is 29 weeks of gestation, right? And you are having no cuts available, okay? Or you have only or you don't have NICU, right? Right? Okay, so that's mean that you need to transfer this patient. So I can await the suture delay, suture removal for 48 hours maximum, right? He can say this, or he can ask about the type of the anesthesia needed. Okay, it's a high circulage. You need to do it under regional. That's it. Okay. You get the point, guys? So it's whatever is a question. Since touched this part, you should be able to choose wisely in the exam based on the words that leading you to the scenario, right? So this is the corresponding part for the Swiss. Postnatal patient with raised blood pressure measuring 159/69. Examination show exaggerated ankle clonus or absent. I don't know how exaggerated or absent. Exaggerated ankle clonus means that she is in a preeclampsia, imminent eclampsia, and I want to give her the magnesium sulfate. Absent is something else. How can they write this? Anyway. Funny, mashallah, funny, wallah. People recalls the question in both ways and opposite direction. Yes, absent or exaggerated clonus, and you solve. Trust me, I wouldn't trust their what they remember about the or they recall about the potassium level, since they are not sure it was exaggerated or absent. Clonus. So believe me, I wouldn't trust this. Potassium level was high. Okay. Okay, that's good. So I wish that there was option of shift to ICU. Okay, I go to the ICU if the potassium level is this high. Okay, so if anuria is there and patient had okay. 1 second, 1 second, 1 second. Okay. So here maybe it makes sense. Patient have high blood pressure. She received the magnesium so, or not? Anuria was there. Okay, so the problem was in the high potassium, my friends, right? I think it was about magnesium toxicity, mashallah. So there was a magnesium toxicity or not? Okay, my friends. Okay, let's agree something. Okay, this scenario doesn't make sense. Okay, she may receive the magnesium sulfate. Okay, anyway. Okay, guys, look, my friend. If the patient have anuria, okay, high urea, significant proteinuria, and a potassium 7.1, what is this problem? Forget now about the high blood pressure. What is this problem? Yes, this is acute kidney injury. Right? Yes, 100% AKI. Okay. Who will treat acute kidney injury? Is it you? ICU. Okay, good. So shift the patient to the ICU. Okay? Okay. Can I give nifedipine? No. Methyl dopa? No. I wouldn't touch the patient who has AKI, right? Because with this high level of potassium, she needs stabilization right now. Start oral nifedipine? No. Okay? Magnesium sulfate? No. I wouldn't start with the patient who have AKI, right? Start oral lapitalol? No. Lapitalol IV? No. Hydralazine? No. Start on magnesium sulfate regime? Again? No. Furosemide? No. Okay? So the only option that can work in this case is shift the patient to the ICU. Okay? Yes, calcium can help, okay, with the high potassium level, but I wouldn't do this, Dr. Fatima. And alhamdulillah, it's not in the options. Okay? Why I wouldn't do this? Because it's not my job, right? If you have confirmation of a patient who have acute kidney injury, okay, you need MDT, right? Correct? Okay, so option H is the most suitable option here, my friends. Everyone agree? Yes, I can't give magnesium sulfate. No, I can't really. Maybe they choose the magnesium sulfate for a reason, like as we said before, recalls because it's not complete. Maybe while they are solving, they think that maybe there is doubt. What is this exaggerated or absent reflexes? What is this? Even this can go with magnesium toxicity. You know, if the magnesium toxicity is there, I would give the calcium gluconate, but I wouldn't give magnesium, of course. Okay. So let's see what Dr. Nada sending. Renal replacement may be indicating severe renal management of women chronic kidney disease, serum urea above 17. Okay, Dr. Nada, but yes, I know that. Thank you very much for sending the summary for the AKI, but we wouldn't take steps. Really, if there is option to shift the patient to the ICU, I wouldn't take the steps. Wait, can you see calcium? Can anybody see calcium? I can't even see calcium here. So, no, ما في calcium. Yes, no. There. Yes, I know. Okay, shift the patient to the ICU. Don't give calcium. You're obstetrician, okay? This option is very good, safe option. Unless you have to choose the drug. Like you have no other option and you have to choose the drug. For a patient who have magnesium sulfate toxicity, you will go for calcium. Gluconate for patient who have high potassium, calcium is good, of course. Okay? But you do have a safe option of going to the ICU. I will go to the ICU myself. Okay? A postpartum woman developed chest pain and hemoptysis. 3 days. Okay, so I agree. Thank you. Yes, two consultants agree that ICU was the best option. Yes, my dear, I agree as well. I agree. ICU is a very safe option for us. We are obstetricians. A postpartum woman developed chest pain and hemoptysis 3 days following delivery. She was already on 3 days of enoxaparin 40. She was significant history of gastric reflux, okay, disease. Auscultation showed a clear chest. Her parameter, hemoglobin is 97, respiratory rate 16, SpO2 98, pulse 120, heavy smoker, weight is 98. What is a possible diagnosis? Okay, so what do you think, my friends, for this patient who have chest clear by auscultation and she had hemoptysis 3 days following delivery and chest pain? Did this patient receive the correct prophylactic dose? Not all the patient with pulmonary embolism will have problem with the oxygen saturation at the beginning. Okay, so this is a wrong prophylactic dose. What else? This is not a pneumonia, not any type of pneumonia. This is not bronchial asthma, sorry. What asthma? I'll tell you, when you think of peripartum cardiomyopathy, you think of the peripartum cardiomyopathy when he tell you, okay, Signs of cardiac failure. Right? Patient have heart failure signs. Okay. Woman in premenopausal age referred from another specialty. For incidental finding of 4cm simple ovarian cyst in the right ovary, what is the recommendation? Okay, this is a premenopausal. Premenopausal 4cm, nothing. Yes, good. You are ST5 doing an elective cesarean in low-risk patient. When you open the peritoneal cavity, you notice multiple engorged blood vessels in the lower uterine segment. What will you do? If 4cm cyst in postmenopausal, you have to do CA 125 and count the risk of malignancy index. Okay, this is if it is a postmenopausal. So now here, my friends, we have so many options actually. Okay, what you know, that if you have engorged blood vessels in the lower uterine segment, you wouldn't proceed, right? You need to call your senior, right? Right? Yes, you never proceed. Why not most senior? What is most senior here? Apply figure of 8? No. Categorize blood? No. Call the senior most obstetrician. You need the who's you wanted to call the HOD? No, you're not. You need to call the consultant of the day. Even if emergency cesarean section, okay, and still there is time, you will wait your consultant. Your consultant should be minutes away, right? Right? In cases if the baby is delivered, you will deliver the baby, or the like for example, there is acute bradycardia, okay, and you wanted to save the life of the baby, deliver the baby and don't touch the uterus or the placenta, okay? But you are in elective situation, low risk patient, just wait like the guideline, okay? Even if it's an urgent, okay, deliver the baby and don't do anything, okay? Like urgent in the case of acute fetal compromise, you deliver and don't touch. But for example, emergency cesarean for non-progressive labor, then just wait, you can wait. Yes, there was a fetal bradycardia, then good. If fetal bradycardia, you deliver and wait. Okay, if this is an option, you go for it. Antenatal patient came to the A&E, history of accidental fall to the toilet. Examination show labial cut. Okay? Properly with a knife. She insists that she fell in the toilet. Okay? And nothing further. What is the appropriate action? Look, my friends. Okay? What is the patient age? This will make a difference in your choices. Okay? Okay. Patient child. If the patient is 18, less than 18, okay? What you will do? Immediately you will call, okay, the safeguarding team in the hospital. This is first, okay? And then inform the police. Right? Okay, the first contact, stepwise approach. Yes, I know, Dr. Fatma. Okay? So, a stepwise approach. First contact is whom? Safeguarding first. Okay? So, it will be the safeguarding first. Because the safeguarding team is in your hospital. Every hospital should have their safeguarding team, right? So the first level of contact for you as a doctor, okay, that you are going to call the safeguarding team in your hospital, right? First. And then they are going to take the further steps, right? Clear, my friend? So far? Okay, that's clear. Okay. So my friends who told me that the age was 29. Okay? So age 29 here, I would question, right? The situation or the event, right? Then, yes, I would speak to her, right? Why? Because we wanted to offer her help. Can I inform police? No. Okay? Yes, no, I can't inform the police, right? Can I offer psychological assessment? Why psychological assessment? No. Okay? Can I inform the social service? No, I wouldn't also inform anybody without her consent. Any organization outside the hospital, I can't reveal any information without the patient. Okay? I can't reveal any of the information if the patient doesn't want. Okay? Okay, so what can I do? Look here, my friends. Local authority has duties, right? To make or cause to be made, okay, inquiries if has reasonable cause to suspect that the adult is experiencing or at risk of abuse or neglect. Determine whether any action should be taken. If so, by whom? And what action should be? All local authorities have safeguarding adult procedure to support such inquiries and coordinate action with partner organization. Okay? So, what I can do, the only thing I can do, okay, is the adult safeguarding. Okay? The only thing or the only people that I can inform is the adult safeguarding. Otherwise, nothing. I would, if I have option, if this is the only option here, to respect her wishes and not to disclose the information, I would follow Dr. Grace. Okay? If I have option, patient doesn't want anybody to know, I wouldn't disclose any information without her consent. That's a good option. No, never. Nothing to be done. Adult safeguarding without patient consent is wrong, Dr. Ala. Dr. Ala, is that an option in the exam? Okay, so if this was not an option in the exam, no, no. Look, my dear, if I do have option that patient doesn't want to disclose the information, I would respect her wishes. Yes, 100%. Okay? I can't inform anybody without her consent. Okay? So any option that contain, inform anybody or take any action without the patient consent is rejected. Completely wrong. It's a big case in your part 3, okay? And it's considered as a safety issue. Okay? I can't inform police. I can't inform anybody. I can't take any decision for a patient, okay? If this patient doesn't want to disclose the information and she's adult. Finished. Okay? I can't report anything if the patient doesn't want. Guys, let me say something, okay? Okay? You would document. Yes, you have 100% to document the finding, the clinical finding. You know why? Because the clinical finding is what you will be asked for, right? I have seen, I have examined, I have said to the patient replied to me, she denied, and that's it. Okay? You got the point, guys? So documentation for yourself, your own clinical notes, it's your right. It's your job. Nobody is going to question that. But patient doesn't want to report what you consider as FGM or abuse, it's her right also. Okay? I can't do anything for the purpose of protection if the patient doesn't want to disclose. If the patient comes with her child in the exam, there was the same but has a child. Okay, that's very good. That's a very good situation. You know why? Because 100%, okay? 100%. 100% again. If there is a child in risk, you have to protect the child. Okay? So, if there is a child, domestic violence with the involvement of children, you have to report. Okay? In this case, it will be safeguarding and child protection service. 100%. Okay? If there was a combining child, any child at risk, even at home, okay, you would involve, okay, the authorities. Why? Because you wanted to protect the child. We have agreed in this discussion, my friends, in the FGM, at that time when we discussed the FGM in our course, we have agreed that my concern is whom? Because you have to accept her, there is an autonomy, okay? And it's a principle. So people, they have the autonomy. She is a sensible adult. She report whenever she feel comfortable to report. My job is to provide her with help. She refused the help, then thank you. Guys, people refuse to be resuscitated in situations where they are almost died or they refuse to receive blood when they die. And the law gives them this, okay? So why do you want to deny the right to not to disclose information about abuse or whatever? Okay, so who said that we should inform and blah, blah, blah? I'll tell you, my friends, it's from the FGM law in the UK, because you are considering that labial cut is FGM or abuse, right? I will give you both document, the UK publication, okay? Look, my friends, The Serious Crime Act reinformed existing FGM legalization and introduced mandatory reporting of FGM in whom? In whom? Under 18, by healthcare worker, teachers, and social worker to the police. Right? Okay. So this is what they mention about the under 18. Right? Okay. Here, if FGM is confirmed in girl under 18, either on examination or because the patient parent say it has been done, reporting to the police is mandatory, must be within 1 month of confirmation. The requirement here for reporting, look, okay, reporting. The requirement to report depends on whether an adult or a child is affected. Okay, so it's a different, yes, it's a different. We don't deal with both as the same. Okay, FGM is a child abuse, and any child with confirmed or suspected FGM, a child considered to be at risk of FGM, must be reported. If necessary, without the consent of the parent, information should be shared with the general practitioner and health visitor. Clear so far? This is what? This is for child, right? Okay. Look, my friend, here, continuation of the point of reporting in the law. There is no requirement to report a non-pregnant adult woman aged 18 or over to the police or social service unless a related child is at risk. So this part from the law is clear? Aged 18 or over. Do I need to report to social service or police? No, unless what? Unless a child is at risk. So if I have a second scenario in the exam with a child is present, yes, protect the child. You got the point? The patient right to confidentiality must be respected. If they don't wish any action to be taken, no report to social care or police should be made in these cases. Happy so far? What if she's pregnant? If she is pregnant or she had a young child at home, in this case, report is a must. Okay? So, in the exam, that's why they play this game and they make you. They give you 16 years old or 17 years old. She had a labial cut. What you will do? Report. 100% you have to report. Also inform the police. Starting from safeguarding team to the social service and police. This is a must. Why? Because under 18. 18 and above, she doesn't want to report, then respect her confidentiality. I hope it's clear so far. Okay? Because I have seen, by the way, I have seen this question circulating in the social media groups. Okay? And everybody give opinion. But I actually never, ever, okay, have seen somebody quoted this part from the law, okay, and put it as evidence in the answer. So in the discussion, it was all personal opinion between the student and candidates. But I actually hope that everyone can take now a screenshot from this. It's available in your guideline, in the FGM guideline. But if you wanted to take the screenshot of this, please take it now, okay? So you would understand the difference, okay? The reporting depends whether it's a child or an adult. Okay? Back to the questions, friends. Thank you very much for my friend who said that there was an option to respect her wishes and not to disclose. This would be the right answer for a patient who is, okay, who is adult, okay? If a child is at risk, pregnant woman and with a child at risk, then report, okay? "16-year-old came in labor with no prior antenatal care. So far, her pregnancy, midwife examined her and informed you that she had type 2 FGM. On inquiring, the girl admits the same. She went to deliver a male baby. What is the appropriate management?" Now, I don't care about the gender of the fetus, male or female. I now care about the mother. The mother herself is a child, and she is a child who have type 2 FGM, right? And she's also a teenager mother. So this case need what? Do nothing? Of course, no. Inform police immediately, not actually. Before discharge, why? Inform police within 1 month. This is partially correct, maybe. Let's see all option. Inform social service before delivery. She comes in labor, okay. So I would inform the social service, but let's see. Okay. Inform social service within 1 month. No, this is too late. It's a good option. Okay. Record in the HSIC dataset with anonymization. With anonymization, no, actually, this is not the mandatory action that to be taken. Okay, so my friends, patient in the hospital, she came in delivery. Okay, who is my smart candidate who will give me the correct answer? Patient in the hospital. I have a situation now. Inform the police first or child safeguarding service first. I will inform the child safeguarding service first. Okay? Why? Because I need to do something now to protect her, right? So the safeguarding team is going to come. They are going to provide her help and support that she needs. She is a child, Dr. Taslima. She is 16. Okay? This is for the mother purpose. It's not about the baby. It's about the mother. Okay? And teenager pregnancy, by the way, whether she have FGM or no FGM, you have to involve safeguarding team social service with her. This is apply for all teenager pregnancy. Yes, I would inform the safeguarding services now in the hospital, okay? And they would inform the social services as well, okay? Why? I will tell you. She is vulnerable, right? She's vulnerable or not? She is vulnerable, right? She is 16 years old. She had FGM and she had a child now. What do you think what will happen to this girl when she go back home? You don't even know if she have a home or not. She have no prior antenatal care, right? Okay, so Dr. Taslima, my dear, you need to repeat reading the FGM guideline again. For under 16, under 18, okay? This is need to be reported, okay? And the situation, believe me, this is what I'm trying to explain. The situation is, I have unbooked teenager pregnancy, comes to me in labor. She's also have FGM, put her in another risk. She delivered. Are you going to just ignore all this situation? Will you? If you did that, then you have no 0 point to safeguarding. You don't do the duty of care to your patient. Leukemia. What do you think the problem this girl will be in? Can you give me 3 problems at least? Okay. Unbooked pregnancy. 16 years. She had FGM. Okay. Yes. Okay. So this is high risk social problem, right? If you leave her, just go from the hospital, this is child leaves the hospital, what will happen to her? Do you know what will happen to her? Do you know she had home or she is homeless? Do you know who is she's pregnant from? Do you know who make her pregnant? Anybody? Do you know where is her parent? Do you know her family is going to kill her or not, since they have done FGM for her already? Do you know what is the background? You don't know anything about her. Okay? This is a high risk social problem. What you need to do, whenever you have a patient with red flag background, whenever the safety is an issue, okay, there is what is called the safeguarding team in the hospital. Okay, and the safeguarding from the name, it's protecting the safety of the patient, guardian of the safety of the patient. Okay, safeguarding team in the hospital usually would be like a midwife. Okay, that is, she's working this job. Okay, sometimes would be obstetrician in the hospital involved also in the safeguarding. Okay, so there are members of the safeguarding team in each hospital. Okay, so now you are going to inform the safeguarding team, right? What is the safeguarding team in the hospital will do? They come to her, they will offer her more about her story, right? Social background, okay? And then they are going to contact the social service for her. When they are going to contact the social service for her, somebody from the social service, like a social worker, will come. Why? Because the social service will take over this patient when the patient is discharged from the hospital. Provide home for her if she doesn't have home. Okay. Provide even food for her if she doesn't have. Protection if she needs. Okay. So the social service, okay, is going to offer the social support needed for this young child who is now become a mother. Okay. So you're starting from which team in the hospital? Start from the safeguard, then social service. Okay, when the police is informed, this is a good one. Okay, police is informed in the cases of FGM when? Within 1 month. No, it's not only in acute, in less than 18. Okay, so also police will be involved when? If that girl, for example, is pregnant as a result of abuse, right? Correct? So I do have 3 levels that provide care to the patient who are in a social trouble. Okay, victims, 1, 2, 3. This is inside the hospital. Safeguarding team is always inside the hospital. Social service, okay, is for outside. When she is discharged, they will take care of her, okay? And when she is discharged, they will continue, okay? Police will do the job, okay, of investigation, but Police, not the first one to be involved in this case. You get the point, guys? So it's not now the mystery of the FGM. I think that you have mystery of FGM, okay? It's not the mystery of the FGM. This is high-risk pregnancy. Teenager, okay, with FGM, no booking. I have 3 problems, okay? So this girl, she needs protection, starting with the safeguarding team in the hospital, okay? Right? So this is how you will go, okay? When to go for a police first in any situation? When you have acute crime. This is where you will go for the police from the 3 out of them, okay? So if you have social safeguarding, okay, let's say safeguarding, social service, and you have police, okay? In acute crime, go to the police first. Otherwise, social problem or complex social situation, go for safeguarding team, okay? You worried about the child after delivery, go to the social service, and so on, okay? Yes, alhamdulillah. Patient has consented for hysterectomy with ovarian preservation. During hysterectomy, one of the ovaries pedicle started bleeding profusely. What is the next step of the operating surgeon? Inform the patient and proceed. So the patient is already during the hysterectomy, okay? If the patient is under spinal or something, okay, I would inform the patient. But if the patient is unconscious, okay, no, there is no here option consent from husband. This is obsolete. No, nothing. Okay. Best interest to apply in emergencies. Yes. Okay. Obtain consent from her LPA. No, I don't want to consent from anyone. Okay. Hospital legal authority. No. Wake up the patient. No, this is very cruel. Okay. So if the best interest concept is there, I would apply it. Second opinion for what? If she started profusely, if the consultant is available, okay, then you would call the consultant, right? In emergency, you can proceed. But the question here is that was the oophorectomy necessary? Why removing both? No, I just look, my friends. If any intervention is needed to save the life of the patient, you go for it under the best interest. Okay, that's it. For emergency, best interest is applied. Okay, unless the patient have a decision before. Like, for example, the Jehovah's Witness, if the patient have said before, if I have bleeding, don't transfuse blood, for example, okay, then in this case, I wouldn't do anything because the patient said that before. Otherwise, patient have bowel injury, patient have vascular injury, patient have any problem, deal with the situation as an emergency to save life. Patient complains of hirsutism, acne. She had diagnosed with PCOS on irregular medication. She had tried various hair removal methods and resorted to shaving and waxing now. How to manage? Okay, so how would you manage, my dears? Okay, so do you have any preferences, like use of Dianet? So sabretirone acetate and ethinyl estradiol, right? So if it is there, I will go for it. Is that a moderate to severe? Is that a moderate to severe? Okay. Look, my friend. So she's waxing and shaving. Yes. Look, my friend, we recommend the first line treatment with contraceptive pill for women not seeking fertility. Okay? So this is a recommendation. First line treatment with contraceptive pill for women not seeking fertility. Clear? Look here, under this point, there is two notes. The Endocrine Society Guideline 2018 don't support use of one COC over another. Okay. However, many of these women suffer from obesity and they are at higher thromboembolic disease with a COC pill. We suggest using the UK eligibility criteria for contraceptive use and counsel patient about risk and benefit. Okay, so here the Endocrine Society guideline didn't actually say something over the other, right? Good. So here the NICE suggests use of what? Dianet. Okay, the sabretirone acetate and ethinyl estradiol for the treatment of moderate to severe hirsutism in women of reproductive age. All other COC will use is off license for hirsutism. Okay, women must be counseled about the twofold higher risk of VTE in order to make an informed decision. Okay, anti-androgen therapy. Okay, didn't say the Dianet here. Say the anti-androgen therapy. Like what? Could you please mention anything like consider the anti-androgen therapy? Okay, good. So those are different examples. Can be used as second line treatment in views of its teratogenicity. Okay? It can be used local, Dr. Hamida, right? Metformin is not routinely recommended for the treatment of hirsutism and PCOS. Okay? So when he tell you COC or he make it specific as the sabretirone acetate, which one you will choose based on the NICE recommendation or what the NICE suggestion? Yes, I will go for C. Okay? Patient underwent emergency salpingectomy for ectopic pregnancy. Her husband, he was at the sea for the past 6 months, okay, returns and asks about her status. What you would do? Screen is there. Just I will refresh. What do you think? See now? Can you see the screen, my friends? Okay. So what you will do? Can you disclose information? Okay. Tell him that you need to go through the case notes and defer for 1 week till you check with the patient. No, can't tell anything. Disclose everything? No. Written? No. Did you speak to the patient before speaking to the husband? No. Offer to speak to the husband only once? No. Discuss the hospital management before speaking? No, I wouldn't speak actually. Refuse speaking at all. I would actually refuse speaking at all. Inform the husband in front of the patient? No. Encourage patient to tell her husband why I would do this. Okay. No, I wouldn't actually speak to the patient before speaking to the husband. Okay, all options not good. I have two only options to compare between. Refuse speak at all, or call and discuss with the patient regarding permission to disclose to the husband. E or K, speak to the patient before speaking to the husband. No, because the K is somehow, okay, just saying something about taking permission from the patient regarding disclose and so on. I wouldn't disclose. I like H. But also refuse speaking at all is like aggressive option, but the only thing that it's not, why not J? Encourage the patient to tell the husband, no, we don't encourage anything. It's a personal problem. It's up to the patient to tell her partner or not. Guys, first of all, I would say something here. So can you see this red line? Can you see this red line? This red line that you will never cross, right? What is this red line? Disclosing the information. Okay? So you never cross this red line, okay? You will never disclose this information. Okay? Clear? Okay? This is a social problem that we never get ourselves into. Yes, exactly. Okay? So, but in the same time, refuse speaking at all sounds aggressive. Right? Sound aggressive, to be honest. So if there is option like I wouldn't disclose the information, I will go for this option, okay? So it. No, 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 no. She had a procedure, okay? And what I can tell that everything is fine, she is okay, okay? I think you need to speak to her. That's it. That's it. Okay? So this is what I can say. Otherwise, if you do have anybody who attended this exam and can remember if this was the exact choice, yes, we will never, yes, we will not put ourselves in this situation ever. Okay, so if you do have option not to disclose the information, go for it, okay? No problem, my dear. I will try, but anyway, no disclose of information, no disclose. And not to encourage. It's not our problem. Encourage her or lying to her husband, it's up to her. Look, my friend, if you are there attending and listening, okay, to the patient telling her partner that she had, for example, a mastectomy and removed, you will never comment. Okay? So you wouldn't speak, you wouldn't comment at all. Ma'am, why we don't inform as breaking bad news? We need to inform them. Inform whom? You want to inform the husband? Are you sure? I want you to go to the ceremony of the MRCG. Okay, so I want you to be graduated from this college, okay? If you said that, they will never let you out. No disclosive information. I wouldn't speak. Believe me, I refuse speaking at all. Okay? It's not my problem. I wouldn't disclose to anybody. Believe me, I would go for it. Yes, it's not like refuse request. It's about that I wouldn't speak to the husband. If he asked me about her general condition, I would say that she had a good general condition, but I wouldn't lie. I wouldn't disclose. No, both I wouldn't do. No, she will not come to you. She will suit you. She will see you in the court. Patient was on copper T. Contraceptive. Her cervical smear showed actinomyces-like organism. However, she is asymptomatic. How to proceed? Nothing. Thank you. Yes. Okay. 40-year-old in a stable relationship for the past 28 days become unwell with features suggestive of sepsis. Ultrasound show complex mass on the right adnexia. Lab parameters show elevated totalocytic count, CRP, and she was on copper T contraceptive for the past 11 years. What is a possible causative organism of this status? MashaAllah. 2 questions on that. Okay, so actinomyces. 32 weeks antenatal patient present with fever, 39 degree, raised CRP, examination show tender uterus. He's antenatal, oh my God. Fetal heart sounds is 180. Okay, so you do have a patient with suspected chorionitis maybe or tender uterus. Okay, so what you will do? Broad spectrum antibiotic, yes. Offer antibiotic, perform emergency, administer crystalloid, no, offer steroid cover, admit and observe, offer induction at 34, no. This will be antibiotic. Better than observation. Why observation? Yes, admit and start antibiotic, not admit and observe. She need a broad spectrum, yes. Patient came with history reduced. Patient came with, but if it is there, then go for it. Patient came with reduced fetal movement at 25 weeks. She had multiple bruises all over the body, so we have a domestic violence case. When probed, she confirmed domestic violence, claims her husband is a good man, but short-tempered. She begs you not to report him. How to proceed? No, here you must report to the Safeguarding and Child Protection Service. I hope you understand, guys, why we choose this. She is pregnant. Okay, and there is also reduced fetal movement. Yes. Okay, whatever the patient age here, it doesn't matter since she is pregnant, there is the child. Her examination show footling breach. Okay, an emergency cesarean was performed. She is complained of infibulation or known case of infibulation. Okay, what is advised with respect to her de-infabulation? Oh, okay. So this patient, she have FGM. And the patient who had FGM, she came in footling breach. That's why they did emergency cesarean, right? Okay. And the question here, when to do the de-infabulation, right? This will be in the postnatal follow-up. She will be seen. She will have an appointment, okay, in the clinic, right? You will refer her. And she will have an appointment. This can be done afterwards, electively, okay? She wanted done, okay? 1 second. She wanted the infabulation and wanted done, but couldn't as she had an emergency. Question was during section, re-infabulation not done, what to do? Yes, dear, look, I'll tell you something, okay? There is a guideline that is called FGM. You know this guideline? You know this guideline? Yes. This guideline FGM, it has here. Okay. Algorithm at the end, my friend. Look, here in the postpartum, what is the advice? Okay. Offer postnatal follow-up if de-infabulation performed intrapartum or if planned de-infabulation did not occur because of delivery by cesarean section. Clear, my friend? I'll tell you how they do exam, how they build the question in the exam. They open the guideline like this. Okay? You take consent. Why not? Okay? Patient, she given consent for de-infabulation, right? Antenatal. Then when she come to the delivery, it was emergency cesarean. Emergency cesarean is done, right? She is now postnatal, correct? When you will do the FGM, this is the question, right? Yes. Okay. She will have outpatient appointment. Postnatal follow-up if the patient, she had and the de-infabulation did not. Okay? So when he give you options and says, do the de-infabulation before discharge, can I agree? No. Even if there was a consent there, no, I'm sorry. Right? So I will give her appointment, a postnatal follow-up appointment. So when she come to the clinic, then we can arrange when to do it electively. Clear, my dear? And it can be done in the clinic. Yes, it can be done in the clinic. Why not? In the gynae clinic. Okay? See? This is your exam. They bring part from the guideline, 2 lines from the guideline, build a question on it, give you different option. However, what they want the exact words of the guideline. Because it was an emergency. Patient requested de-infabulation during, now you have agreement plan, okay? For the patient who had antenatal and she had FGM. So you are telling her, okay, Miss Sandra, when you come to the labor, we will do the infabulation. She said, okay. You have the consent form and then you give her information about the de-infabulation. You give her consent form, she signed everything. At that, based on that, when she comes in labor, we will do the infabulation. On that day, she came to the hospital. Dr. Isra was there. Okay, she was the doctor in call. She found the footling breach, cord descending. She takes the patient to the emergency. She did the operation, finished the operation. Okay, no FGM is done. Right? So now what you will do? Simple, make it simple. Give her appointment for the follow-up in the postnatal. Okay, in the postnatal, she will meet another doctor. The other doctor will have an agreement with her when to do it. And that's it. Why you are making a fuss? Okay? Patient is 24 years old. Question in the chat box. Came for labor room. She is 2 cm. 2 cm and you are able to examine. Wait for the de-infabulation till the second stage. But you're not able to examine and it's early in labor, you can do it early in labor. De-infabulation. It's not about social surface at all. Social surface at 24 years old, no need at all. Okay? And do nothing. How I will do nothing? She had FGM, right? So if the patient had FGM, she comes in labor, I will read the part of intrapartum from the guideline and I will see, okay, when the de-infabulation is done intrapartum. It can be done in labor early if the examination was difficult, like you can't examine her vaginally or you can't insert the catheter, so you can do it in the first stage of labor. Otherwise, we do it before the delivery of the head, right? This is intrapartum care of the FGM woman. If the woman require intrapartum de-infabulation, the midwife and obstetrician caring for her have completed training on de-infabulation or should supervise appropriately. If the de-infabulation planned for the time of delivery not undertaken because of resource to cesarean section, then the option of perioperative de-infabulation, okay, like just after the cesarean, should be considered and discussed with the woman. Labial tears with the FGM should be managed in the same manner as women without FGM. Repair should be performed where clinically indicated after discussion with the woman and using appropriate material and technique. If the vaginal examination is not possible, or intrapartum procedure or urinary catheterization are not feasible, then de-infabulation in the first stage of labor should be recommended. Clear, my friends? You can do it while you are doing the cesarean section electively, guys, if you do have agreement with the patient. Type 1 or type 2 or type 3, Dr. Ala, what will make you think of the de-infabulation? The clinical examination. Look, my dear, some patients with type 2 FGM have fibrosis and adhesions. Okay, fibrosis over, for example, okay, the urethral opening. And it's difficult to insert the catheterization. So in the exam, it's not about type 1 or 2 or 3. In the exam, it's about the finding and your ability, okay, your ability to perform an examination. He must write this, okay? If there is no narrowing, no fibrosis, then it's fine, no de-infabulation. Why you will do de-infabulation? We do only the de-infabulation, okay, in case I have problem, okay, in access, right? And unfortunately, Dr. Ala, the types of the FGM is done by different methods. I have seen patients where you can't really insert like 2 fingers. They're just stitching the patient up. Okay? So some they don't remove parts, okay? But they stitch. They make like a scar and a stitch. Okay? And I have examined some patient, it was very difficult to insert 1 finger even. Okay, so it's all about the examination finding. If there is narrowing and there is difficulty to do examination or to do delivery, you would do de-infabulation. And of course, we would do the de-infabulation before the delivery of the head, because I don't want tears. This is a fibrous tissue, right? So the possibility of tearing is great. And if it teared, it will be difficult to repair afterward. So that's why we do the de-infabulation, right? To help. Sometimes I even arrange the de-infabulation to a patient while she's not pregnant at all, because she had recurrent UTI, because some patient will present with difficulty, like patient have postcoital bleeding. I'm examining her, I can't insert the speculum. So in this case, we can discuss the infabulation and do it. Okay. And the most difficult types of the FGM I have seen really in my life was the African types. Okay, it was very difficult to manage the patient actually without making the de-infabulation. So it's not about which type, it's all about the ability to perform the examination and the access, okay, to the organs. Either it's a gynecology procedure or it's a delivery procedure. If you do have a problem, okay, then discuss the infabulation. So don't be tricked in the exam if they tell you type 2, okay? And then after that, they describe narrowing or fibrosis. Don't be tricked. Thank you, my friends. Stop playing, okay, with the colors. Thank you. Patient came for discussion for delivery plan. She delivered the forceps previously and led to obstetric anal sphincter injury. She was asymptomatic. Her follow-up showed a defect in the sphincter. What is your advice regarding delivery? Yes, the infabulation can be done antenatal at the mid-second trimester. If you find that the patient is difficult to examine, okay, so antenatal FGM can be offered. So if there is defect in the sphincter, advise the elective cesarean from 39. All women who have sustained the obstetric anal sphincter in a previous pregnancy and who are symptomatic or have abnormal endoanal ultrasound or manometry should be counseled regarding the option of elective. Postpartum patient came with complaint of flatus and fecal incontinence following her difficult forceps delivery and obstetric anal sphincter. On examination, episiotomy was well healed. She was unwilling for the rectal examination. What is the investigation that could be offered to her? It's very easy. What you will do? A transperineal ultrasound. Previous CS patient, known mild asthmatic, was being actively managed in the third stage of labor. Estimated blood loss now reached 500. What is the appropriate step? What second? What is this? Is that a retained placenta? What is this? Estimated blood loss now reached 500. What is appropriate? What you will do? Buttonhole is the defect in the repair of the. How would you repair? Why you are care about the repair of the anal sphincter? No. Forget about the manual removal of the placenta. Yes. What you will do? She's actively managed in the third stage of labor. Now this is a mild postpartum. What is the appropriate next step? Stepwise approach. We have just solved one question like this in the MQ. I didn't say anything والله لسه. I didn't say anything. Okay. Would you rub the fundus? I don't know. If this is a retained placenta, then I would do the manual removal of the placenta. But do you have anything that say maybe retained placenta was there? My champions who attend the exam? Okay. So what is the action that I will do in response to postpartum hemorrhage? Okay, called for help. Now, okay, rub the uterus, the fundus, and castrize the bladder. Right? Stepwise approach, right? Correct? Why I would repeat first? Stepwise approach, my friend. Stepwise approach. I can give ergometrine, right? But do you have any information about the patient atonic uterus, not atonic uterus, anything? I'm just waiting for my future colleagues, the future members of the college. Yes. Okay. Continue your discussion, please. In the management of postpartum hemorrhage, yes. What you will do if you have a mild postpartum hemorrhage? They told you that the patient have 500 ml loss, right? After they have actively managed the patient, what you will do? For minor cases, do I need to do anything, or I just leave her till she completed major blood loss? Examine the patient, right? Alhamdulillah, right? Good. So if I don't have any information about the patient status, uterus is atonic, is not atonic, right? Placenta is completed, not completed. What I will do? Clinically, the first thing that I will do, what is it? Active third stage of labor and still have postpartum hemorrhage. Now finished the rule of the active third stage. Now I want to assess what is the reasons of the bleeding, right? Correct. Examine your patient first and then decide what to do next. Right? What could be the possible reason in this case? Anybody knows? Atony. Okay. Tear. Tissue. Right? How would I know? Please examine your patient. Okay? Thank you very much. Okay. Many actually. Okay, if there is a retained placenta, let's say this question is about retained placenta. What you will do? Let's say it's a retained placenta question. What you will do? Before you examine the genital tract, you will examine the uterus is contracted or not. Believe me. Okay, so after 30 minutes, okay, of the retained placenta, what you will do? For the retained placenta, intravenous access should be secured, okay? If the woman is bleeding and she had retained the placenta at the same time, you will give intravenous oxytocin. If the placenta is retained and there is concern about the woman's condition, then offer a vaginal examination to assess the need to undertake manual removal. Explain this assessment can be painful and advise her to have analgesia. Okay? For the management of retained placenta, this is must be in a theater, okay? Okay. You are performing emergency cesarean on a patient from sub-Saharan Africa with a known HIV status, assessed by ST3. During the surgery, the ST3 had a needle stick injury. What is the next step? Immediate action following occupational exposure to reduce transmission risk. For skin exposure, the site should be washed and with soap and water. Small wounds and puncture may also be cleansed with antiseptic. For example, alcohol-based hand hygiene solution. Okay? In cases of mucosal exposure, the exposed mucous membrane should be flushed with copious amount of water. Eyes should be irrigated with saline or water. Okay? Squeezing the wound to express blood is not recommended. Okay? Okay, friends? There was a scenario in the old exams about that there is a blood that came in your eyes. So what you will do? Yes, you have to wash with a water or saline. Okay? If the index case is unknown of HIV status, okay, and she is coming from a high prevalence country, okay? Okay, would you think that the post-exposure prophylaxis is recommended or not after needle injury? Not, okay? So, for here, okay, for sharp injuries or mucosal splash injuries, okay, or needle stick from discarded needle in the community, for example, okay? So, and the person comes from high risk country, but the HIV status is unknown. You are not sure. Okay? So would you take the post-exposure prophylaxis? So generally not recommended. Okay? Yes. Okay. So generally not recommended unless you have a reason, okay, for doubt. And in this case, you can consider it like this. The risk of HIV transmission is very low. The potential toxicity and inconvenience for the PIP is likely to outweigh the benefit unless there is a clear specific factor which increase the risk. Okay? So that's meaning of generally not recommended. So it can be individualized decision, right? Okay? Because the index case is unknown HIV status. But if known HIV status, right? Positive, then of course PIP is there. Patient was evaluated for postmenopausal bleeding 3 months ago. Her investigation and biopsy had been normal. However, she presented again with similar complaint. How to evaluate her? Patient presented for postmenopausal bleeding and it was normal. Then recurrent. What you will do? She must be referred urgently, right? To the postmenopausal clinic, the one-stop postmenopausal clinic. You know what happened in the one-stop postmenopausal clinic? There will be facilities for the diagnosis and taking sample in the same day. Taking the biopsy in the same day, okay? She need hysteroscopy and biopsy, of course. Okay? I don't have here option of urgent referral to hysteroscopy. It's their postmenopausal clinic. And the postmenopausal clinic, it has the facilities to perform all the necessary investigation in one place. That's why it's called one-stop clinic. No, he just said patient evaluated for postmenopausal bleeding and they come again. Usually the patient presented again for her GB. Okay. Options, if there is TVS or hysteroscopy, go for hysteroscopy and biopsy, of course. Okay, so 1 second. If you are sure options there that it was urgent, it was urgent to hysteroscopy. It's not about the TVS nowadays. خلاص, it's finished. Recurrent, better to go for the hysteroscopy. Okay? TVS was also there. No, I wouldn't go for the TVS. I would go for the hysteroscopy. Okay? Okay, so let's say TVS. Good. It was like this. Okay, good. So you will go for hysteroscopy and it would be urgent. This is urgent, this is routine. Your friend says that it was about the time. Is it urgent or is it routine? Okay. Recurrent cases, we send, my dear, for the hysteroscopy. It's not about the sickness nowadays because it's recurrent. Okay. Patient present with features suggestive of PID. She report inconsistent condom usage. What is her management? PID. Inpatient, outpatient management of the PID. Okay. Yes. Look, my friend, for the outpatient management, starting by the intramuscular ceftriaxone. Okay, this is what should be 1 gram. Okay, then intramuscular ceftriaxone first, then followed by or plus doxycycline for 14 days, 100 mg 2 times per day for 14 days, plus oral metronidazole 2 times per day, 400 2 times per day for 14 days. Okay, this is one of the most widely used regimen. Okay, so here I'm looking to the ceftriaxone IM option. Which one? This one. Okay, so ceftriaxone, doxycycline, but we need flagyl, we need metronidazole for rest. The other option, okay, will be the ofloxacin, right? Twice per day also, okay, for 14 days, plus metronidazole for 14 days. So the ofloxacin, okay, for 14 days with the metronidazole is the complete one here, okay? This one missed the metronidazole. So C. Okay? Yes, this is the closest fist, of course. Yes. C. Anyway, in exam you have to remember, right? You have to remember between the outpatient regimen and the inpatient regimen. Patient present with itching and no associated rash at 28. Itching, no rash. Okay. So this jaundiced. Oh. So lab show bile acids 20, ALP 120, AST 40. What is the appropriate management? Okay. So now what do you think for a patient to have jaundice, itching, right? No rash. Viral screen AST at 40. Okay. Guys, when your patient, okay, has jaundice, what do you think you need to do as test? Adding for the testing. Is jaundice normal with the cholestasis? I wish that there is option to refer to hepatologist. I would like it actually. Yes. Induction of labor. Okay, so how about her liver condition? She is only 28 weeks. So I'm sorry, the C is not an option here. So what you will do, my friends, if this is the only available option? So we need to test further, right? We need to know what is the reason of this patient, why this patient have abnormal features, right? Or associated features. Right? So she need to investigate it for other reasons. Okay, so what you will do? Viral screening or you will do autoimmune screening? Okay, yes. Then we have to do further screening or further test for screening to know what is wrong with this patient, right? Otherwise, if there is option for hepatology, hepatologist referral, would you go for it? Yes, yes, you were referred for it. I hope it was there actually. Viral screening, my dear Dr. Mona. This is what we are speaking about. Patient presented with chest pain during the postpartum period. She was started on low molecular weight heparin. Examination show bilateral crepitation on her lung. ECG show Q wave and ST elevation. Right bundle branch block. Okay, X-ray was abnormal. What is the next step? Abnormal means CTBA. Postmenopausal underwent CT for orthopedic indication. She was referred in view of her endometrial thickness showing 10 millimeter. How to evaluate her? Tell me, please. Okay. No complaint. Okay. Yes, we are evaluating postmenopausal bleeding. Okay. Patient was oxytocin for augmentation. Her blood were reviewed for epidural anesthesia. Showed serum sodium of 126. How to manage hyponatremia again? So I need to restrict the fluids, right? Yes, well done. Yes, well done, well done, well done. Okay. Here, patient was posted for elective cesarean for placenta previa. Junior was inserting a central venous line, and patient went into cardiac arrest. CPR was started and fibrillator attached, which show pulseless activity. She was given initial dose of adrenaline and CPR continued for 2 minutes. AED continued to show pulseless again, electrical activity. What is the next step? Okay, so look, my friend, what happened this patient? Junior was inserting what? Central venous line. Patient went into cardiac arrest. What happened? What is the reason of this patient going into a cardiac arrest? Pneumothorax. Yes, okay. CPR was started and fibrillator attached. Show pulseless activity. Initial dose of adrenaline is given and CPR continued for 2 minutes, but still pulseless. Okay, then what is the next step now? If you have pneumothorax, would you repeat the adrenaline or you will do a chest tube? Okay, so that's why I'm saying, my friends, if you have, okay, if you have, my friends, if you do have a patient with a reason, known reason, okay, will you keep him giving the adrenaline? Okay, or will you treat the pneumothorax? Okay, so you agreed for the chest tube. Where you will insert it? Fourth, okay, space, intercostal space. Okay, so which option can fit here? Mid axillary, mid clavicular, which one? Mid axillary, right? Yes, okay. I don't know this thing. So the heart stops now. I think when we remove the tension, we can help the heart to get back, right? Okay, so we will go higher, right? Right? Okay. So in the pregnant patient, right? Especially in the third trimester, it can be placed from the first to the third intercostal spaces, right? But where? Mid axillary or clavicular? How many weeks she is? She's in the cesarean, right? Yes, it's elective for placenta previa, so she must be third trimester. It would be H in this case. Yes. So the one with the mid-axillary line, second intercostal space is H. Don't worry, my friend. We will answer H now, okay? And I will consult one emergency consultant. Okay? For the pregnancy, would we do it here exactly mid axillary line at the second intercostal space, or we could make it in the mid clavicular? I think it's in mid axillary, but just I would confirm and tell you. Okay, Dr. Basma, just to confirm and tell you, I can't really claim that I am aware of the best between which approach is the better in this case, in the cases of emergency. You know what? I'll tell you. Last month, my husband asked me to attend the course of critically ill patient. Okay, this is a course for surgeon. And he told me there is a pregnancy chapter. Okay, how to deal with a critically ill patient. Then I asked him about the timing. It was actually 23rd of June. Then I told him, no, no, it's very near to the exams and I can't do it. Okay, I think I will book the next course. You need a critically ill patient? Okay. We need everything. Actually, next month there is a course about the computerized CTG, the RCUG course. Inshallah, I'm going to attend it. Needle chest compression. So Dr. Nada is sending something for tension you generally recommended. Okay, so Dr. Nada, you want us to choose the mid-clavicular line? Yes. Dr. Nada, by the way, she is certified advanced life trauma support. So we'll take her consultation. Okay. Patient present with severe PMS. She tried CBT, COC for her symptoms. However, they failed to relieve her symptoms. She was put on GnRH agonist for 6 months, which allayed her symptoms. She was in DIMBA. Okay. DMPA, contraceptive, her 2 months symptom diary show pain during the second half of the cycle. She's stressed at work and started to get suicidal thoughts. Oh my God, how to manage her? Very poor patient. Okay, so what is her problem? Her problem mainly during the second half of the cycle, right? So what I will give, I can start with the luteal phase support, right? Okay. In the option of behavior therapy, vitamin B6, okay, Combined new generation pill, either cycle or continuous or luteal phase, low dose SSRI, like citalopram 10. Okay. In the second line, okay, management, it would be the estradiol patch, okay, plus micronized progesterone, or plus Mirena for the endometrial protection. Higher dose SSRR, continuous or luteal phase, like the citalopram 2240. Okay, so our patient here, she is in which line? So CBT, she tried. COC, she tried. Okay, and she even tried the GnRH analog, which was helping her symptoms. Okay? Yes. Okay. Look, my friends, can I go for the hysterectomy for this patient? GnRH can be used for diagnosis or not? Yes. Okay. So one means that if she uses a GnRH agonist and elevated her symptoms, means that this is confirmation that this is related to the PMS. Okay? So this is not done. Third line not done yet. Third line is not done yet. This sentence means that this is a confirmation of her problem. Okay? This sentence means that this is a confirmation of her problem. Okay? So now my patient tried COC and CBT. What is next? Is the next is the low dose luteal phase or high dose luteal phase? Actually, suicidal thoughts, this is will need a psychologist. Okay? And I hope that there is a psychologist referral here. Right? Yes, this is a severe symptoms. Okay? So, yes, do something for her. What you will do? I wish I have option, okay, for the outback therapy. So any help from my friend who attended the exam? This is option, ma'am. Which option, my dear? Any other option? You finished third line. No, she did not finish third line. Okay, so if this is all option, okay, and the patient have already tried the CBT and COC, okay, and she had, okay, and now she had everything is done. Once he said suicidal, actually, I don't agree for luteal phase. Luteal phase is not enough. I can't really offer this luteal phase. It's not correct. You know, if he said even continuous, I would go for the continuous as a trial. But suicidal thoughts is really something that is dangerous and serious. Okay? Patient have already tried everything, even the GnRH is there. Okay? Yes, suicidal is a red flag. Okay? And I can't offer a luteal phase with the suicidal. This is no. Okay? She was not done second line, but other option won't target suicide ideas as good as SSRI. Would there an option for a continuous SSRI? No. There was an option for psychologist or psychiatrist. Both options are not there. Okay, go to surgery. This is the only thing that I can do. Then you go to surgery. Yes, yes. Okay. So I would only go to surgery in this case. It's not about the third line with that we have achieved. But look, my dear, I can't offer COC again. Low dose luteal phase SSRI is not suitable with a suicidal. Suicidal, this is something that is really severe. Okay, suicidal thoughts mean that this is something severe. Offer high dose luteal phase? No, no, no. Again, I can't offer a luteal phase. This is unstable. Okay, this can be used for mild to moderate cases. Okay, or at the beginning of treatment. Offer CBT she had tried already, and we are beyond this, right? So the only option that can be applicable here will be the hysterectomy. Yes, Dr. Sarah, just you think about it by exclusion, okay? Because luteal phase you can't offer. No other option is there, right? Patient had already tried the GnRH, means that this is confirmed that all her problem comes with the PMS. We have reached to the suicidal thoughts, means that we have to do something. Okay? If you flagged the question and you marked the question, okay, it will be counted, no problem. Okay? If it was correct answer, it will be counted. Wrong answer, it will be counted, okay? But if flagged the question unsolved, of course, it will not be counted. Okay, my friends? So patient here finished the therapy. She received the GnRH for 6 months. Symptoms return back. Okay. In this case only, and suicidal thoughts. In this case only, I do have the hysterectomy to offer. I think 10 minutes, inshallah, or 15 minutes, and we'll finish, okay? So here is another version of this question. A 43, or the EMQ, okay? 43-year-old patient completed her family, diagnosed with premenstrual dysphoric disorder. She had tried all the medication, which were ineffective so far. She put on GnRH agonist and add back tipolone for the past 6 months. How to manage her further? If only same options are there, you will go again for the hysterectomy, right? Yes, this is very clear for the surgery. But for the suicidal, there must be something like a psychiatrist or at least a continuous therapy. Otherwise, go for surgery. A 29-year-old, antenatal visit, history of previous baby born as FGR, anomaly scan at this time show uterine artery PI of 90. Okay? And with normal fetus showing no anomalies. Okay, so this is a good time to revise this FGR. Okay, so my friends, the PI of 90 centile is okay or not okay? Okay, when to consider that there is a problem, increase resistance? 95, good. Okay, so what you will do now? She will need only follow-up, right? Correct? Okay, so just a follow-up. Yes, okay. So this is for the patient who's high risk. Everything is normal. Then serial ultrasound from 32 every 2 to 4 weeks until delivery. Okay. Multipara was an epidural analgesia, examined to be fully effaced and fully dilated with vertex at +3 station. There is bradycardia, which will now lasted more than 6 minutes. What is the most appropriate management? So if the baby is at +3 station, what you will do? Delivery, right? Okay, so the delivery now in the room or in the theater? In room, right? Easy. Patient was evaluated for postcoital bleeding. Her cervical screening show on examination, cervix was found to be friable. So what you will do? This need urgent, okay? Right? Yes, exactly. Urgent referral to the colposcopy. Scenario describes severe dyskaryosis. What is the referral time for colposcopy? 2 weeks time. Yes, exactly. Patient underwent LITS for cervical cancer stage 1A1. Biopsy shows CIN3 at the margin. What you will do? It was cancer. There is still to the margin, extension to the margin. What you will do? Okay, I have option between repeat excision or LITS or test of cure. What you will do? Then repeat excision, right? He didn't say what is the method of excision, but it's preferred to be cone, right? How is the trainee assessed whether is making satisfactory progress and on track to achieve the educational objectives? The annual, yes. So ARCP, an injury to her lumbar spine, following which she had used crutches for walking. She's 33, no, sorry, 36 weeks pregnant and now complains of back pain all the time. Her pain seems to have worsened and she had resorted to wheelchair to move. She was already on paracetamol, codeine for her pain, but this was ineffective. How will you manage? So we have a problem with the pain. Right? Who is the person dealing with the pain? This is an anesthetist, okay? Yes, for pain management. And also for the planning for pain management option also during labor. Patient underwent ultrasound at 36 and the estimated fetal weight 3.6, gross at 90. AFI is high normal. What is the next step? So if the sensitive fundal height more than the 90 centile, you consider ultrasound. And if the ultrasound diagnosed the macrosomia or for gestational age, okay, diabetic team referral, okay, and explain the limitation of ultrasound. When to deliver this baby? Is there a recommendation for early delivery? It's actually all about counseling, okay? At 40, yes, at 40 plus 6. That's it. I think, Dr. Grace, this is a repeated question, was large for gestational age. Maybe 95 was there and it's written only as 90. Patient presented with preterm labor at 36 with primary herpes infection. Examination show that she is 6 cm with bulging membrane. How would you manage? So still membranes are intact, which is good. And this is primary herpes. What you will do? You need cesarean, right? Okay. Will you start here on acyclovir? Yes, please. Why no need? Look, my dear, the one you can consider the acyclovir for the patient who in labor at primary, okay? The one that no need for antibiotic is the patient who is group B carrier and she had elective cesarean. So in this case, no need. Okay? What is the management of a patient with HIV presenting with primary herpes infection in the 3rd trimester? Is there any problem here? She had HIV, primary herpes. Why suppressive dose from 22? Why 22? 32. Okay. So treat now, right? This is third trimester, what you will do? Continue their labor. Okay? If she got earlier than the third trimester, then we start from 32 suppressing dose. Right? This is the point that it was updated in the guideline and it's easy now. Patient underwent medical termination of pregnancy a week ago. She presented with bleeding, uterine cavity. Her HCG was 43,000. What's the next step? Molar, okay? So what you will do? Look, my friend, if the patient presents with bleeding, active bleeding, then it will be a suction curettage under ultrasound guidance by consultant, right? Suction evacuation, there is no difference. I think this is just a repeated option. Surgical, no, there is a difference. This is surgical, or this is suction, okay? So I wouldn't do the surgical. Sorry, my friend, I think that my concentration is now gone. Okay. With suction, molar, so choices with suction was referral. First to GTN section. You deal with the bleeding now, my dear, and then refer. Okay? So if you have a bleeding now, patient have bleeding now, you deal with the bleeding now and then refer. Bleeding now and then further investigation. Okay? Manage bleeding at the moment, stop bleeding, and then do the further investigation. No. Curate. Surgical means that you will do a curettage. Suction, be more specific that you are using the suction. You're not going to insert an instrument inside. Okay? Antenatal patient present with erythematous rash with blisters, which started at her hand and feet and spread to the entire body. She had fever, malaise, and joint pain. What is the possible cause? Blisters, vesicular rash. What is a vesicular rash? Varicella, yes. Okay. Okay, last question, my friends, and we'll see. Gravida 2 in labor. Previous baby delivered by forceps due to delay in the second stage. The baby weighted 3.3. Diagnosed with GDM during the pregnancy. She was on metformin. Scan at 32 showed that the baby is 95 centile. She was induced. Now patient is fully, and she's pushing actively for 1 hour. The CTG be normal. Examination show that head is 0.5 palpable, and by vaginal examination, the vertex is +1, left occipito anterior. No descent with pushing. Contraction 3 in 10, moderate to strong contraction. How to manage her? Look, my friends. I'm sorry, guys. So, look, my friends, our patient here contracting 3 in 10. So, no oxytocin for her, right? But the finding, okay, can apply instrumental or not. Yes, yes, you will apply instrumental. Where? Where? Theater. Exactly. Right? So, no contraindication to assisted vaginal birth, go for it. Right? Even if the baby sounds to be big baby. Okay? That's why you are doing it in theater. Right? If delivered, delivered, not delivered, go for cesarean. Okay, no descent with pushing, but no contraindication for instrumental delivery. So it's, look, my dear, high risk patient. Okay, not easy delivery. Okay, so what prevents you from having a trial with all the precautions of trial? Nothing, right? You can go for trial. If the baby, like, in the trial, you do a gentle traction and you see, and if there is descent with the traction, what you will do, and so on, okay? If you do have with the instrument, okay, progress, then it's fine. No progress, go for cesarean. Stop the procedure and go for cesarean. I don't have here a contraindication for, okay? No, we don't push for, we don't let the patient multi-para push for more than hour. No, okay? And this is not good signs for progress. That's why you will not leave her for another time. Okay? She is multi-para, already 1 hour pushing, no more time. No more time for her. Especially that there is no signs of progress, okay, that you will go for, leave her for more time or something, okay? If you have a multi-para pushing for 1 hour and the baby is descending nicely with each contraction and baby now is at low station, then you can give like 10 minutes and see, right? Or 15 minutes and see. But no, this is high like this and no descent with pushing, so she need help. Okay, sometimes no descent was pushing because there is some asynclitism, maybe a little bit of rotation required, even it's left to occipital anterior, but sometimes the instrument just corrected. Okay, so if something like this, it will come easy, it will be delivered in the theater. If nothing, okay, with the precautions, with the safety precautions of the instrumental delivery and no descent, go for the cesarean, turn it into a cesarean. Okay, why I would go for a cesarean directly? Give me a reason. No signs of CBD. Do you have here irreducible molding or you have excessive caput? If I have those, of course I will go for CBD. If I have high head, 2/5 palpable, I will go for cesarean. Okay, my dear? So I can't just assume based on no clear recommendation to go for a cesarean section in this case, my dear. There is no also contraindication listed in the assisted vaginal birth. Okay, so you can take the decision yourself in your labor room. And to be honest, if I was in the labor room and delivering this patient, I would be like 90% going for a cesarean, and I will let her know that I'm going to do the instrumental delivery as a short trial in labor. okay, in means that in the theater, okay, before giving the anesthesia and open her abdomen. But this is my own practice, right? In the exam, we are just dealing with a calculation, right? No contraindication, then apply assisted vaginal birth. No clear recommendation in any guideline to say go for cesarean. Okay? So this is what you will do. 5 cm after 4 hours become 6 cm. What is next? This is, my dear, called a suspected delay in labor. What is next would be in 2 hours. Okay, my dear? So you take the action first, amniotomy, and then repeat abdominal and vaginal examination in 2 hours. Yes, Dr. Nada, my dear, she is the one responsible for all our material. So I will send her the modification of the answers. Okay, and I'm sure that she will upload it. Don't worry, my friends. Oh, thank you very much, Dr. Lena. Thank you very much, my dear. Really, I'm hoping that you like the session. Inshallah, you will pass the exam and we will meet together in a post-result, inshallah, celebration. Dr. Basma, she says, repeat, voice interrupted. No problem, my dear. So, Dr. Basma, if you have 5 cm after 4 hours, is 6 cm. This is what we call a suspected delay, SD, suspected delay in labor. What is the action? ARM, okay, will be offered. And then 2 hours, we call confirmed. Then oxytocin if it is needed or labor. Okay? Thank you so much, my dear friends. Thank you, Dr. Maisa, my dear. Thank you very much, Dr. Shahinda. Thank you so much. I appreciate all of you, my friends, attending today. Jazakumullah khairan. And inshallah, you will find your exam very easy. And I hope that we have learned some lessons from today. Dr. Basma, believe me, still ARM you do first, and then you think of assessment in 2 hours. Don't worry about it, okay? Thank you very much. Thank you. Assalamu alaikum, my friends. No, even look, my dear, Dr. Hamida, my dear, even if the patient had already ARM done or she refuses the ARM, no problem, you still assess after 2 hours. Still, we call suspected delay after the first examination and the confirmed delay after the second examination. Okay, so stepwise approach, it will be ARM and then re-examination. If ARM is not there, also re-examination. But we don't do a vice versa, okay? No say questions is there, Maria. All questions are important. And people, sometimes you see something that is very clear or very easy, okay? But you just have a mental block about it, okay? Or you are affected by so many questions that you read per day. I am sure, my friend, that questions now are, chasing you like ghosts, even in your dreams. So, inshallah, you will do very well in the exam. And never mind all this traffic jam, as I told you, in your brain. Okay, this is will all be cleared. Yeah, trial of instrumental delivery is there. Okay. Asking it isn't low, normal is 95. Asking about the gestational weight or what? PI is 90 is okay, my dear. Yes. We have finished like 100 question, my dear. Okay, collected from the questions, and I think that there is nothing new so far. Okay. But I can ask kindly, okay, Dr. Nada, if she post more questions for you guys for discussion, if you want in the WhatsApp group, so you will complete the questions of the exam. Otherwise, believe me, it's just repeated. The next questions are really easy. I have tried to show you, okay, how you will think in the exam if you find a new question or a strange question. And hopefully, inshallah, that you got the idea, okay? So no matter even if there is 10 questions that are difficult or hard or new to you, don't worry, okay, at all. Just focus on what you have already and do your own assessment, okay? Don't be tricked by the detail. The most important thing that what is leading sentence in the scenario, what he wants from you in the scenario, okay? And study postpartum hemorrhage and FGM, okay? Thank you so much, my friends. Thank you so much, my dear friends. I'll see you all in part 3, inshallah. Study well for your exam. Thank you so much. Take care of yourself.